I am Dr. Sarita Berry. Dr. Meenu is there? Professor
Yes,
Dr. Meenu?
yes, I'm there. Yeah. Hello.
Okay. So you can allow to start.
Yeah, please. Namaste and good. I think it's going to be good evening only. So I think it's very nice that we've got an opportunity to start this virtual ophthalmic conclave from Aios, and we are very thankful to them. And good luck and best wishes to all our speakers. So I think let's start from our first speaker, Dr. Sarita. Would you like to start introduction? Yeah.
Dr. Ben Limbu is there?
Yes, he's there.
Dr. Ben, will you'll start your topic on insight on entropion management?
So namaste to everyone.
Namaste.
Today I'm going to talk on, sorry, I started from the last. Talk on the lower eyelid entropion management. So before starting my presentation, I would like to disclose that I have any financial interest to disclose for this presentation today. Before jumping into the presentation, let me talk about a little bit about the anatomy of the eyelid. This is very important before we start our management. So anterior lamella, which comprises skin and auricularis. Similarly, posterior lamella consists of tarsus, conjunctiva, and middle lamella, which is orbital septum and capsulopalpal fascia. This diagram here depicts the different layers. This is the orbicularis and skin, tarsus and conjunctiva, and the tarsus is held by inferior capsulopalpal fascia and orbital septum together. So the eyelid is a kind of suspended structure right from the medial canthus to lateral canthus, and it is definitely held by in position by capsulopalpal fascia and orbital septum from below. If there is no capsulopalpal fascia and orbital septum, you can imagine the tarsus would be hanging. So we know that surgery is the definitive cure for the entropion per se, but when I started doing a surgery, I had a lot of recurrence, and I later realized that I did a wrong surgery on the patients because I thought that every patient is same and every patient needs same surgery, and I did same surgery for all when I started initially. So what is the optimal correction that patient need? Before going to that, we need to understand how our eyelid is kept in position. So to have the eyelid in normal position, the orbicularis should be functioning normal, which means it should be in normal position and with good innervation. Similarly, tarsus should be with good thickness, height, and tautness. Capsulopalpal fascia should be in place. Position of the eyeballs should be as it should be, and then similarly the skin, orbital septum, orbital fat, and conjunctiva should be in normal. To understand the lower eyelid stability, we have two tensions in the lower eyelid. One is horizontal lid tension that are exerted by tarsus, orbicularis, medial and lateral canthus, similarly conjunctiva. And then vertical lid tension is usually contributed by inferiorly by capsulopalpal fascia, and of course nerve supply to inferior rectus and orbital septum contribute significantly for vertical lid tension. So when we evaluate a patient with lower eyelid entropion, we should see the position of the eyelid, punctum, snapback test, lid distraction test, fornix depth, lower eyelid excursion, and Sarmas test should be done. To assess whether this is horizontal or vertical lid weakness or laxity, we need to do snapback test. If it is more than 2 seconds, or lid distraction test more than 8 millimeter pull, and lateral and medial canthal laxity, this indicate that there is a horizontal lid laxity. Similarly, less lower lid excursion, absent of lower eyelid fold, deep inferior fornix, and there is a white line below the inferior tarsus from the conjunctiva side that significantly indicate that the retractor weakness or dehiscence. We have the category of entropion as senile, cicatricial, spastic, and congenital. Each entity is different. So most common type is involutional. So it has horizontal lid laxicity, retractor dehiscence, overriding of preceptal to pretarsal. Similarly, it also has other factors like orbital fat atrophy, tarsal plate. There is a elastic fibers deposition with ACE, and loose skin and orbital eyes also contribute for involutional entropion. The other one is cicatricial entropion, which is more difficult one to treat. These are secondary to chronic inflammation like herpetic infection, trachoma, Stevens-Johnson syndrome, ocular cicatricial pemphigoid trauma, surgery, irradiation, glaucoma medicines, or chemotherapy can contribute for this kind of entropion. So how to differentiate between senile and cicatricial entropion? This is most important thing to do in our clinic. So on lid eversion, you can easily pull back the lid in involutional or senile entropion, but whereas in cicatricial entropion, it's very difficult to pull back the lid margin. Similarly, when you evert the lid margin, in involutional or senile entropion, the eyelid remains in position for some time before the next eyelid blink. But in cicatricial, it immediately rolls back. And there may be presence of symblepharon and congenital scarring cicatricial entropion. So the other one is spastic entropion. These are usually, it happens and it goes away by itself if the local irritation or infection is treated on time. But most of the time, the old age patients have some kind of irritation, and that actually aggravate asymptomatic involutional entropion and make the entropion more prominent. So we have to be very careful while examining the patient. And then the last one is the least common type is congenital entropion. And then there's a malformation of capsular pulpal fascia in these patients. So management, conservative management like topical antibiotic, lubricants, topical taping of the lower eyelid. And then, of course, the definitive treatment is surgery. Either we do horizontal lid tightening or lower eyelid retractor tightening, orbital therapy in terms of Botox or surgery, and posterior lamellar surgery is the last choice for the entropion. So I'll quickly demonstrate a few cases here. This is a Quickest procedure, which used to be very famous before, but now it has been not done routinely because of high recurrence, like 50% recurrence up to 2 years follow-up. And then we do more commonly nowadays, like Jones procedure or Witch procedure, which I'm going to demonstrate. This will actually correct the capsular pulpal fascia dehiscence. That means the vertical lid laxicity is managed by this procedure. Here is a video to demonstrate. I'll quickly go through this video. This is a involutional entropion. You can see that the eyelid margin doesn't roll inside immediately, and there is some laxicity. After injection of anesthesia to the eyelid, we go through and through cut in the lower eyelid, which is 4 millimeter below the tarsus, and then we expose the tarsus as well as capsular pulpal fascia. That's the tarsus there. This one is tarsus, and this is capsular pulpal fascia, the white glistening structure along with the conjunctiva. So we tighten this in this procedure, and then we do actually horizontal mattress suture here. 2 to 3 sutures in place. And then finally, we suture the skin, either interrupted or you can use continuous sutures. And then upon opening the lid speculum, you can see that the correction is immediate. And similarly, we have a tarsal strip procedure, which will actually correct for horizontal lid laxicity. It tightens the horizontal lid laxicity, most common procedure performed throughout the world. And this is another video to demonstrate how we do our horizontal lid tightening, that is lateral tarsal strip procedure. So, sorry, I was demonstrating the video, but yeah, we exposed the tarsus like that. We cut the extra amount of lateral tarsus that is not necessary. And then finally, we stitch that tarsal strip to lateral periosteal margin. And then the rest of the things are just closing the skin. So this is a lateral tarsal strip procedure that will tighten the horizontal lid laxity. The other one, which is very difficult, cicatricial entropion, which happens usually after trauma. And this is one of the most difficult case. We usually do a free autologous graft from hard palate or tarsus from the upper eyelid of the opposite side or same eye. And then sometimes ear cartilage and donor sclera are also used. Here is a case to demonstrate. He has a road traffic accident and he has a entropion, cicatricial entropion on the right eye. And we release all the scarring from the patient, and there was a large defect of conjunctiva from inside. So we took a ipsilateral upper eyelid tarsoconjunctival graft, and we placed that down. And this is how it looks immediately after the surgery. And the other one is Botox injection. This is given to patients who has spasmodic entropion, 5-unit, 3 sides, upper and lower eyelid. In pre-tarsal area is sufficient to treat spastic entropion. So in nutshell, senile entropion has not a single issue with the eyelid. So it has horizontal lid laxity. Similarly, it has vertical lid laxity, overriding of preseptal to pre-tarsal, and fat atrophy and tarsal atrophy are also there. So to address this issue, we have to do our multi approach. So it is not like just doing a lateral tarsal strip or doing a wedge procedure as I demonstrated earlier. We have to combine all the procedure to address the actual etiopathogenesis of the senile entropion. Similarly, cicatricial entropion, always posterior lamellar supplement should be there. Any spastic, we have to either use quick cuts for temporary, or we can give an injection Botox. And congenital, we can always do advancement of capsular pallor fascia to the tarsus. Thank you very much. So the summary is we have to tailor our surgery according to the etiopathogenesis the patient has, which has to be examined meticulously before we proceed to management. Thank you very much.
I think it was a wonderful presentation. In a short while, Dr. Ben, you have covered a lot of all the types of entropions of the lower lid. I think if there are no more questions, then we can go to the next participant. Thank you, Dr. Ben. So the next participant, Dr. Raksha, she's there?
Yes, she's there.
Yeah. Yes, I'm here. Yeah.
So Dr. Raksha can proceed with your topic. Your topic about Zepto precision, pulse capsulotomy, assisted cataract surgery for mature white cataract.
Thank you, ma'am. Good evening, everyone. Today, I'm going to talk on precision pulse capsulotomy, commonly referred to as Zepto, assisted cataract surgery in mature white cataract. So I'm Dr. Raksha from Biratnagar Eye Hospital. So like, as we all know, the cataract surgery is the most commonly performed surgery in our setting, in ophthalmos setting. In our hospital, as much as 80% is the cataract surgery, and rest 20% composed of other surgeries. So it has become increasingly common, and it is safer nowadays. And the nowadays the rapid advances in the technology over the cataract surgery, like the IOLs, the method for a nuclear fragmentation, the method for capsulotomy has all increased. So that's why it's becoming more safe, more common. And there's always an increase in demand for phaco surgery. Less patients are opting for the SICS surgery because we all know, like, more patient wants, if they want the phaco surgery. And it is always a challenge in case of intumescent of a mature cataract to do the capsulorhexis, because there's always a chances of radial tears and flag sign, Argentinian flag sign. So, as it's a prerequisite to have a very good rhexis in case of for uncomplicated phaco surgery. So in white cataract, for an experienced surgeon, like, they may go in for the spinal rhexis, which is like initially creating a small rhexis and then you gradually increase it to the desired size, or by creating or initially making a very small CCC, doing your phaco, putting the IOL, and after placing the IOL, you can even increase the size of the CCC. For an experienced surgeon, this may be it not be a very that much of a challenge. But for a new surgeon, it might be quite difficult. So in those cases also, like, that's why the ability to reproduce a perfectly sized and circular capsulotomy has spurred much of the recent clinical interest. So because of that, many centers had adopted the femtosecond laser capsulotomy. Like, this is a method in which the femtosecond itself create a capsulotomy so that it makes the work of the surgeon very much easier for a phaco surgeon. But however, it has a lot of disadvantages, like the surgical center may not have a femtosecond laser for that procedure. And secondly, the need for eye docking compromise the surgical efficacy. So you need for the workplace where there is less number of patients, you can take the patient for femtosecond assisted laser capsulotomy and then take the patient again to the phaco OT and then do the phaco surgery. But for a very high volume setting, this may not be that much of possibility. And moreover, the procedural cost of femtosecond laser capsulotomy is relatively very high. And it is also thought that there is the capsulotomy edges from the femtosecond is a little bit rougher, and they may sometimes have a radial tears. So now coming to the Zepto, which is precision pulse capsulotomy. In this, what happens is, this is a technology in which we use a micropulse, we use a frequency laser to break open the anterior capsule by giving a series of electrical stimulation with the help of a disposable handpiece, which is nano-engineered to form a capsulotomy tip, and it has a powered by a capsule. That Zepto has a console which provides the power for the capsulotomy, and it needs it has a handpiece and with a small tip. So what is the advantage of doing a precision pulse capsulotomy is that it was found that the edges of the PPC done by Zepto was relatively stronger than even the manual CCC and femtosecond laser capsulotomy. So what happens is the tip, what does the tip have? The tip has a circular nitinol circular ring, which is covered by the silicone suction cup. And so the property of the nitinol ring is that it is a super elastic shaped memory, and initially put into the anterior chamber. We can make it smaller, and then as you go into the anterior chamber, it can be opened up and it takes up its original size of 5 to 5.0 mm in diameter. And slight suction is needed to oppose the anterior chamber against the bottom edge of this nitinol ring, which is provided by the console. And then it gives a rapid series of electrical pulses of 4 milliseconds in duration to create the perfectly shaped capsulotomy. Now I'm sharing my video with this. So as you make the main piece, And then I'm just making the Zepto the tip smaller to as to fit in from my incision, which is around 2.8 mm. And then as I enter the anterior chamber, I really take out the plunger, and then you can see the nitinol alloy has again gone back to its original 5.5. And this is the suction being created over there. You can see the vacuoles being pulled out. And now the capsulotomy has, the electric pulse has been given, and the capsulotomy is perfectly formed. Now you can see that there is a perfectly shaped center.
Dr. Raksha, we cannot see your video. The video is not playing on the screen.
Yes. The video is not, we can't see the video, Raksha. The video is
Okay,
not
it's not
there.
playing?
No, no.
So should I?
You can restart again.
No, I can just
Yeah,
go
we can
to my
see it
video.
here. Now we can see that. Can you play that?
And now?
Yeah, we can see, but it's not playing.
Can you see it?
Yeah, we can see it. Can you play it again? Hello?
Okay, can you see it right now?
No,
Right now?
we can see only the last part where the surgery
Can you
has finished and the IOL has been put.
Mm-hmm. Oh, one second. Hello?
Hello? No, we can't see. No, we can't see. That video is not playing.
Mm-hmm.
Dr. Raksha, do you have that video apart from the slide? So you can play it apart from the slide. No?
Yeah,
Yeah, I have.
I think maybe we can go on to the slides and come to the video later in the talk also, whenever it starts playing. Dr. Raksha, is it okay?
Raksha, you are mute, I think. You have to unmute yourself. Raksha, you need to unmute yourself.
Dr. Raksha, you are not audible.
Yeah, she's mute.
We can start another and then come back.
Yeah, maybe yes. Or maybe she can finish her slides and then I think she's muted. She's not. Dr. Raksha, I've sent her a message.
Okay, unmute. I have just unmuted.
Yeah.
Can you see my video?
No, we can see your.
Can you see my slides?
No, I think you have not gone to slide share.
Okay. Can you see it?
Yes, we can see your slide now. Yes.
Okay. So I'm sharing the video. Okay. So can you see the video?
No.
Hello?
No, the video is not playing.
No?
No.
Okay.
Maybe you can go on to your slides, Dr. Raksha, and later on we can again come back to the video.
No.
Dr. Raksha, can you go on to your slides?
Okay, like, can I, is this video seen? No?
We can see.
No?
We can see.
the.
Yeah, okay. This is the video. Like, I made the side, the main incision. From there, I'm putting in the Zepto handpiece. Like you can see, like, and after
The video is not
it,
being played. The video is not being played.
Yeah,
Just
we can see only the folder where the video
The
is.
folder.
You have to play the video now.
okay, okay. My slides are visible.
Yes, slides are visible, but your video is not playing.
Not playing.
Dr. Sarita, can we go to the next presentation and Raksha can just fix it up by that time?
I also think so. I also think so.
Yeah,
Dr.
maybe-
Lalit, Dr. Lalit Agarwal, is it okay, Dr. Raksha, with you? We'll come back to you again.
Hello,
Dr.
Raksha.
Raksha?
I think she's not.
Yeah,
Raksha?
Dr. Lalit,
okay, yeah, it's okay.
Yeah, you can just fix it up. By that time, we can have another presentation.
Yes.
Dr. Lalit is there? Dr. Lalit Agarwal?
Yes, ma'am. Am I audible?
Yeah, you are audible. Should we start with your retinopathy or prematurity clinical pulse? Dr. Raksha, is it okay? So you may share your share your screen, Dr. Lalit.
Sure, ma'am. Is my screen visible, ma'am?
Yes, it is visible.
Yes. Good afternoon, everyone. So when we talk of retinopathy of prematurity, the first thing is, why do we want to talk of ROP? Or more than 30,000 preterm babies are seen to be having visual impairment due to ROP worldwide in 2010. In the last 30 years, the prevalence of moderate and severe vision loss and blindness due to neurological disorders has increased from 13 to 35%. In 2009, ROP caused more than 100,000 cases of visual impairment and 25,000 blindness. And it is predicted that by 2050, the prevalence of vision loss due to ROP will be more than 100 per 1 lakh population, and among which more than 43 will be blind out of 1 lakh population. So what is ROP? Is it a congenital disorder? No, it's not a congenital disorder. It develops after the child is born. It usually takes 3 to 4 weeks to develop. Normally, when a child is born premature, the retina is not completely grown. Once it is exposed to the normal oxygen of the atmosphere, there is a down regulation of vascular endothelial growth factor, leading to sudden stoppage of the growth of retinal vessels, which is the vaso-obliterative phase of ROP. After a week or two, when the retina keeps developing, there is an attempt to vascularize this developing retina. And during this, in the absence of adequate oxygen, there is upregulation of VEGF. And with this, the vessel tends to vascularize the avascular retina. During this attempt, if it grows normally, there is no ROP. However, if there is abnormal growth of these retinal vessels, there is a chances of development of retinopathy of prematurity. The last 20 years, we have the classification of retinopathy of prematurity given by the International Classification of ROP Group. Recently, in 2021, they had added, apart from zone 1, 2, and 3, they had added a subdivision of zone 2, that is zone 2 posterior, which is an area which starts from the junction of zone 1 and zone 2, and which extends 2 disc diameter from that junction. This zone 2 posterior area is supposed to have an increased risk of further progression and further damage if not treated. So this is why this area has been specifically classified as zone 2 posterior. And in future, it is expected that we use this terminology so that we, especially in research purpose, so that we come to know what is the outcome of observation versus treatment in several stages of disease of ROP. In the recent classification, they have talked more about the plus disease and the pre-plus disease. Whenever we encounter these babies of ROP, it is not very easy to decide on the plus disease and pre-plus disease. These 6 images are from the ICROP 3rd edition, which can be used. The figure A, B, and C have been graded by majority of the researchers as being not plus disease. That is, it is mild plus disease because it has some component of vascular tortuosity, but they do not mark up to the definition of plus disease. However, figure D, E, and F are actually the plus disease, that's indicating severe disease. Aggressive ROP, previously called as aggressive posterior ROP, was thought to be mainly localized in the posterior segment. However, now it is understood that aggressive ROP can be seen in any zone. It actually has prominent plus disease, ill-defined demarcation line, and flat networks of proliferating new vessels. This disease needs to be treated early. So treatment of ROP is mainly needed for severe ROP. Stage 4 and 5 ROP needs vitreoretinal surgery. Threshold disease, which was the indication for treatment of ROP used in the cryo-ROP study, which showed that cryotherapy was superior to observation. Then came the ET-ROP trial, the early treatment ROP trial, which showed that early peripheral laser, before the eyes goes into threshold disease, had better outcome as compared to waiting till the eye develops into threshold disease. The ET-ROP classified this group as pre-threshold disease, and this high-risk ROP, that is a time-on ROP, needs early treatment. That includes zone 1 stage 3 ROP without plus, zone 1 any stage ROP with plus, and zone 2 stage 2 or 3 ROP with plus disease. And these require treatment within 24 to 48 hours. In 2011, we got the results of the BEAT ROP study, which showed that monotherapy with intravitreal bevacizumab had a better outcome in stage 3 plus disease in zone 1, but not in zone 2. Similarly, the Rainbow trial and the Rainbow extended trial had showed that monotherapy with ranibizumab was superior to laser in treating these ROP babies. One should be very careful while going through this study, because 31% of the babies receiving ranibizumab received additional post-baseline treatment to get a favorable outcome. So these babies are likely to have progression as well as recurrence. So a good follow-up and treatment will be required in such babies. So laser needs skills with indirect laser ophthalmoscopy. Also, it needs support of sedation and general anesthesia if one cannot laser under topical anesthesia. And for larger babies, the efficacy of laser is proven, as in ETROP group. Anti-VEGF has a benefit, especially in the zone 1 severe disease. However, there is an issue of skill of injection in the small babies. Also, it is associated with local complications like endophthalmitis and systemic complications which are yet to be studied in detail. Here we can see the top two features are showing a zone 2 stage 3 plus disease, which after treatment with laser, here we can see the ROP has regressed. You can see that the dilatation and tortuosity of the vessels have started decreasing 1 week after treatment. This is another patient of aggressive ROP in which an extensive laser was done, and we could see, though the laser marks are all over retina, sparing the macula, but the disease has regressed. This is another baby with zone 1 stage 3 ROP with a component of going into 4A. This baby was treated with laser therapy and was referred for vitreoretinal surgery. However, unfortunately, the patient lost to follow-up. They did not go for a vitreoretinal surgeon, but luckily the disease stopped with the sequelae of fractional detachment nasal to the disc. This picture shows the treatment of an aggressive ROP with anti-VEGF. Here we can see the inferior two pictures, that is post-anti-VEGF injection pictures, in which the plus disease has gone down significantly 1 week following injection with anti-VEGF. The regression of ROP has been very well described in the new latest 3rd edition of ICROP classification. That is the vascular signs as clearly seen in this picture. The dilatation and tortuosity as seen in the superior pictures have come down significantly. This indicates regression. Other vascular signs include vascularization of the avascular retina. Other signs include regression of the tunica vasculosa lentis, better dilatation of the pupil, and better media clarity. The injection of anti-VEGF in such small babies should be very careful, and the safer ROP protocol helps in guiding us in this. That is use of short needle, antiseptic betadine, follow-up in 2 to 7 days post-injection. Extra attention should be cared to maintain cleanliness of the environment, assess for local infection, and determine the right site, that is around 1 mm posterior to the limbus. Recheck, reevaluate the babies in 1 to 2 weeks, and especially these babies should be examined with a FFA at 60 to 65 weeks post-menstrual age to look for peripheral avascular retina and neovascularization, and treat with laser if needed. Also, the ICROP, this edition has come up with the reactivation details. With the treatment with laser, if treated adequately, the reactivation is rarely seen. However, with the use of anti-VEGF, reactivation of the disease is not at all uncommon. It can be seen at the initial site of ROP lesion, or at the leading edge, or it can be present as in seen in figure F at the previous site, as well as the leading edge of the vascularization. This picture shows a case of zone 1 stage 3 ROP with the component of plus disease on the left side, and in the right side picture we can see after anti-VEGF the ROP lesion has regressed, and there is a development of anastomosis at the site of stage 3 ROP. Anteriorly, if we see, the vessels have started growing, but then again there is a stage 1 reactivation in the form of demarcation line anteriorly. So this picture has both regression as well as reactivation seen with anti-VEGF treatment. There are long-term sequelae with ROP, which we have to be careful: retinal detachment, persistent avascular retina, retinoschisis, macular anomalies, and retinal vascular changes. If we aim to have a nice collaboration with the pediatrician, neonatologist, and have a good referral system, we can aim to screen these babies on time and treat them on time so that we can avoid long-term sequelae and prevent visual loss in these babies. Thank you.
Thank you, Dr. Lalit. I think in a short time, you have covered the whole of ROP. So now we can go on to our next speaker, Dr. Manisha Shrestha.
Dr. Sarita,
Yes.
can I ask him a question? I have a question. It's quite
yes, definitely.
very nice and very interesting presentation of ROP, which is, I think, very most important thing for childhood blindness. Dr. Lalit, you mentioned that
Yes,
you
ma'am.
do an FFA after some weeks, no, 60 to 65. How do you do it in these babies, and how do you take pictures? How do you do it, FFA?
Ma'am, frankly speaking, we do take pictures with the pediatric camera which we have, but the one we have, that is the Trinetra Neo, it does not have an angiography in it. But the latest one, which has come with Trinetra Neo SD, that has a angiography as well in that. Even the Redcam has, and even the Trinetra, the cheaper option, has the angiography component in it. So with the increasing use of anti-VEGF, especially in these babies, in future, I think we will be needing more and more pediatric cameras with these angiography features, because I see very frequent use of anti-VEGF for these babies, even in Nepal.
Because even in our hospital, we are actually not doing FFA for these ROP babies. I think Dr. Ely and maybe Dr. Sarita can tell us what do you do in India. I think a lot of things, maybe they do a lot of ROP. Dr. Azad also, he does so many presentations. It's so nice to listen to him. So Dr. Ely and Dr. Sarita, can you enlighten us?
Yeah.
Yes, Dr. Ely, after you, I can speak.
Yeah, because I'm also involved in RP. Excellent presentation, Dr. Lalit. Really nice.
Thank you, ma'am.
Then the thing is like FFA, because I don't think we have a facility, even in Telangana, we don't have to. So, maybe in India, Dr. Sarita can explain, but we don't do. And only thing is like, I want to ask Dr. Lalit, like when there is a reactivation, as you said, you've shown one beautiful picture of regression and reactivation as a, demarcation line. Do you go for laser at that time?
Ma'am, till date, this year, not this year, in December, I have treated 3 babies in which one of the baby was treated with anti-VEGF in our center and 2 babies were treated with anti-VEGF in other centers. And we could see demarcation line, reactivation. And in that scenario, I went ahead with laser. Like the rainbow study shows that we can re-inject ranibizumab, but in our scenario, I've gone ahead with laser because we will not be able to again re-examine these babies and do an angiography in these babies later on.
Yeah.
So
because with ranibizumab, the possibility of reactivation is very high compared to
yes, ma'am.
bevacizumab. And
Yes,
then so yes, so probably the laser would have that's the best treatment we can offer. So
yes, ma'am. I've lasered in all these cases. Yes, ma'am.
There's a term called PAR. I think it's not, we should follow up with another presentation because shall we stop here or because
you can ask your question, Dr. Ely. If you want to say something, you may. That will help the whole.
Peripheral avascular retina, isn't it? PAR, according to
yes,
new. That does happen in anti-VEGF. That is even after 6 to 7 months, even in a year. So probably that is what the baby had. Do you agree, Dr. Lalit?
Yes, ma'am. The baby had both the peripheral avascular retina as well as there was development of the stage. That is, stage 1 was that's what reactivation. We could see stage 1 along with the peripheral avascular retina.
Yeah.
So since there was reactivation, so that was an indication for treatment.
Yes. Thank you.
So I'll just add on that it is very true that after ranibizumab, almost 80% of the babies, they will need some type of retreatment. We are also doing only laser, and we follow up the babies 10 to 12 weeks post anti-VEGF. And if there's any area which is left avascular, we laser. Because otherwise, in our country, they may not follow up. They may then end up with a lot of problems in the periphery. So therefore, we follow up babies till 10 to 12 weeks. And if they have not been vascularized completely, we laser whatever area is left avascular. We do not wait for 65 weeks post-menstrual age or 6-7 months, because we have seen the babies do not follow up and they come up with problems. So this is our routine. We do it. We do laser. We have never given the second injection of anti-VEGF.
Okay. And
Yes,
what
ma'am.
about FFA? Dr. Sarita?
I have also not done FFA because we also have trinetra. We take photographs to show to the parents and also to follow up a few babies. We also are wanting to have the trinetra FFA later on. Yes, it is indicated where, especially in AP-ROP or even aggressive peripheral ROP, because there when you have to laser, you have to see where avascular area, sometimes it's very posterior. So it helps in lasering even the posterior areas where you may have parallel vessels, but no vascularization. So in cases which are not improving with anti-VEGF and laser has to be done, sometimes in posterior AP-ROP, in aggressive posterior, it may need FFA. Till date, we have never done an FFA. Even for surgeons, FFA is sometimes required.
Yeah, ma'am, I wanted to ask, like, it has been documented in few of the studies that even in the even if after anti-VEGF injection, in the absence of reactivation also, if laser has been done, there is a chances that there can be reactivation later on, because there was peripheral avascular retina. Though we have done a laser, still during the course of growth of the vessels, there can be reactivation. Have you encountered any of these cases?
Dr.
That
Lalit,
is why it is said that it should be confirmed with the FFA.
But if we have lasered completely till the ora, and we have done it, sometimes we do need a barrage laser, which is posterior to the stage where it is developing active disease. Then, and we've never seen that it would reactivate. Laser is a final treatment. Anti-VEGF, you have to keep following up to see if it reactivates. And if the vessels have not reached up to the ora, you have to treat. But yes, in aggressive diseases, whether posterior or peripheral, you have sometimes the reactivation can be there because in case it has not regressed, then the FFA is required. If the vessels have regressed, then you're sure that it will not come up again.
Thank you, ma'am.
Thank you, Dr. Sarita. I think we can go to the next presenter.
The next presenter, yes, Dr. Manisha is there.
Yes,
Dr.
yes.
Manisha.
Yes. Namaste.
Also presenting an ROP scenario at Bharatpur, Chitmani. So kindly go on.
Yes, just give me a minute. Is my screen visible to everyone?
Yes.
Okay, so namaste everyone and a very good evening. I'm Dr. Manisha Shrestha. I'm working as a pediatric ophthalmologist at Bharatpur Eye Hospital. And today I'm going to discuss the scenario of ROP at my setup at Bharatpur. So it's just flows like a story. In fact, like I saw in June 2022, an idea came to me. I wanted to look at what is the number of the premature babies who are coming to us. And I looked at our medical records and I found out that there are very less number of babies that we are screening at our setup at that time, like roughly 2 to 3 babies per month only. So we know that because Bharatpur is blooming as a medical hub and there are lots of hospitals with NICU facilities available, there are lots of premature babies being born, but why are they not being referred to us? That was a question that came to our mind, and we thought maybe the pediatricians are not referring them. So what we did was we organized a CME program So this is a picture of the CME program, which was held in June 2022, where we called the pediatricians and the pediatric residents working in and around Bharatpur. And here we wanted to highlight that ROP as an important issue for preventable blindness among the pediatricians and the residents. So before we started off with a formal program, we also handed out a CAP questionnaire so that we were able to assess their level of understanding about ROP. So in that, in this program, out of 63 pediatrician residents who work in Bharatpur, 43 were present. So it was a good attendance. That is like 68% were present there. And their mean age was 35 plus minus 9 years. And out of the 43 present, 62% were qualified pediatricians. And 32% said they are examining around 11 to 20 preterm children per month. As mentioned earlier, the CAP questionnaire had questions with a total score of 22 points, and more than 50% had an average knowledge score of 10 to 15. So after this program, what we did was we made a pro forma to catch hold of these patients who come for the ROP examination. And that was done from July last year. So till date, we're able to examine around 52 preterm kids, and we ask them to come for follow-up examination, usually every 2 weeks or according to the severity. And totaling up all the preterm examinations, the ROP examination done, till date, we were able to do 90 such. And majority were male, 58%. And the average gestational age was 32 plus minus 4 weeks. The mean birth weight was 1590 plus minus 450 grams. And majority were delivered by a C-section. We also looked at what were the maternal risk factor. 20% had maternal hypertension, and few had maternal diabetes, antepartum hemorrhage. We also had look at the neonatal risk factors. So 10% were on ventilators, few had neonatal sepsis, hyaline membrane disease, and the average days of NICU admission was 11 plus minus 12 days. The average days of oxygen therapy was 6.6 plus minus 8.3 days. So as I mentioned earlier, out of the 90 ROP examinations or observations done, we were able to see ROP was present in 9 of them, and out of which in 8 it resolved spontaneously, but in 1 we had to refer them for the laser treatment and needful. Though we do the ROP screening at our setup, we still lack the adequate facility for the anesthesia as well as post-operative care. So we're not doing the treatment per se at now, which we plan to start. And again, I went back and looked at the number of the preterm kids who are admitted at the NICUs at Bharatpur. That's like 1 year data of 2022. And these are the 3 major hospitals in my area. First one is Bharatpur Hospital, that is the government hospital, and rest 2 are the medical colleges. In 1 year, the preterm kids, that is less than 34 weeks and less than 1750 grams was 248, and majority were in the Bharatpur Hospital, that is 61% admitted there. So now I did my maths to find out how many kids were I able to screen out of them. So roughly it was like around 42%, but still 50%, or half of the people are not coming to us. So now again, it kept my brain scratching about what could be the barriers. So what are the things that are stopping them for having their ROP screening done? So first and foremost, it is the lack of in-house screening facility at these hospitals. What is happening right now is these hospitals, they tend to refer them to us basically at discharge, but the sick ones, the ones who are particularly at risk, are there in the NICU and not being seen. So there's lack of trained ophthalmologists, as we in the pediatric ophthalmology unit and the retina are only doing this. So there is lack of ophthalmologists who can do this in our setup, lack of infrastructure, as well as lack of timely referral by the treating pediatricians for ROP. Also, ignorance among the parents and the guardians regarding how important this ROP screening is so that the preventable blindness can be prevented on time with adequate treatment. And economic constraint, it is going to be heavy on the pockets. Yes, that's true. Then what we know the barriers, so what can be done to overcome them? What could be the way forward? As I already mentioned, these sick babies are not going to come to us, so we must go to them. And we have thought that we partner with these hospitals, or at least Bharatpur Hospital, so that we go there and do the screening and the needful on time for them, as well as to train the ophthalmologists for the ROP screening. And maybe we can also have funding for the fundus camera. We can train the NICU nurses or the medical officers to use them to click pictures, and they can share the same with us. And via tele-ophthalmology, we can do the needful. And also strengthening the ophthalmology services, as it is not a one-man show. It is like a multi-speciality approach which needs to be strengthened. And foremost, to spread the level of awareness among the treating physicians as well as the general public about this preventable blindness due to ROP. So lastly here, I would like to quote what Neil Armstrong said: "A small step for man, but a giant leap for mankind." Doing the small steps, screening these small babies, yes, we are making them cry when we are doing our examination, but that's for their own good. And for that, we are saving the lot of sight years ahead of them, and which is the essence of today. So let us all pledge that we shall all unite to fight ROP. That is all I have to say for today. Thank you all and have a great day.
Very nice presentation, Dr. Manisha. I think you've done a very good job about starting the ROP screening in your hospital and area around you. So I think that's a great step you've taken. Is there a medico-legal problem also in your place around? Because that will actually motivate the pediatricians, the neonatologists to send the babies to you. Is there some cases like this? Because in India also, the medico-legal cases actually motivated all the pediatricians to have the ROP screening, definitely.
Maybe there is, but I'm not sure of. I'm not them.
Okay.
At the time being.
All right.
Yes.
And also the telemedicine would also help you to train non-ophthalmologists to send pictures to you, and you can start the screening with even with Trinetra and telemedicine. And also, I think the government should also take part into this, because the sight years, the economic years, the economic loss which occurs with a blind child is also a huge amount. I think you've taken the right step. All the best to you.
Dr. Manisha,
Yes, ma'am.
according to your data, no, your Bharatpur hospital, like you said, you have 61% of preterm. That's a huge number, isn't it?
Yes,
So
ma'am.
did you-
Total number of the preterms that I just took of the 3 major hospitals in Bharatpur. Major
that
load
is
lies
in 1 year? That's in 1
Yes,
year?
over a period of 1 year. Yes, ma'am. The major load is at that hospital. That is what I wanted to project, so that we are creating a MOU with that hospitals, and we are going to their NICUs and screening at least half of them. At-risk babies can be covered. And we have
1% is a big number, no? I think because Dr. Ely is also there, and from the Ophthalmic Society, when we are there now, maybe you should start this ROP registry or something, and we really know what is the number, and we should work for it, like what Dr. Sarita is saying. I don't think we really have this law. I don't know, or maybe we need to check it with NMC, that do we really have this law telling about this neonatal, these checkups and all that? I don't think so. And one more question, I think like we always tell that the pediatrician should refer these patients for ROP screening. But somewhere I feel that the pediatricians, yes, they are supposed to go for the deliveries. But I don't think that till date, any hospital, because I'm from a very big general hospital, government hospital, but every delivery is not attended by a pediatrician. So most of these deliveries, like if it is a cesarean, if it's complicated, these pediatricians go. So I think you have to call the obstetricians and the gynecologist also, so that they refer you. I think that will be just calling pediatricians. They are not going to refer you all the patients. I think it will be good to call the gynecologists and obstetricians also, where they are involved in these antenatal checkups and they go for these normal deliveries. I think then you'll be able to catch up these patients much better.
Sure, ma'am. Thank you.
Yeah,
Okay, so we can go on to our next speaker,
yeah,
Dr.
sure.
Roshita. She's there?
Just a second, I'll just stop. Share.
Dr. Roshija Khanal? Are you there, Dr. Roshija?
He was there.
She was there, but she's there.
She's not responding.
Yeah, she's there.
Okay.
Dr. Roshija, you can, I think you should start your presentation. I think you're mute. Mute.
Okay, diagnosing posterior uveitis.
I think she's mute or we can't hear you. Dr. Roshija, can you start your presentation? We can't hear you. Are you mute? Can't hear you. Yeah.
I have sent a message also, but I cannot hear Dr. Roshija.
Yeah, we can't hear you.
I'm calling her now.
I think she's waiting for us to say something. I don't know.
Dr. Roshija, please start.
You're not audible, Roshija Devi.
Should we go to the next? Dr. Sanchita is, if she's there, maybe she can.
Maybe we go to the next presentation. Dr. Sanjita is there?
Yes, I'm there.
So Dr. Sanjita, you can start sharing your screen. Maybe then Dr. Roshija will get back.
Sure.
Drug-induced optic neuropathy. You can start on, please.
Is my slide visible?
Yes.
So thank you, everybody. Thank you, especially NOS and Aios IOC committee for giving me this opportunity to present my topic today, which is systemic drug-induced optic neuropathy, more than meets the eye. I'm Dr. Sanchita Sitola, and I'm working in BP Koirala Alliance Center for Ophthalmic Studies. So to start with, I'd like to introduce some terminologies. So there's terminology adverse drug reaction, which basically means a response to a drug which is noxious and unintended, and which occurs as doses which are normally used in man for the prophylaxis, diagnosis, or for the therapy of diseases. Similarly, there's another term, toxic effect, and that means that it is a result of excessive pharmacological action of the drug due to prolonged use or excess dosage. And eye is particularly susceptible to toxic effects of many kinds of drugs, and this is because of its rich vascular supply as well as its small mass. So in 2014, there was a systematic review done to look for the ophthalmic adverse drug reactions. And the commonly implicated drugs in this study they found was amiodarone, sildenafil, hydroxychloroquine, and bisphosphonates. However, in our part of the world, even in India and mostly in Nepal, we see that we are mostly even now dealing with infectious disease, and TB is still one of the top diseases, and ethambutol has been notorious in causing many of our cases of toxic optic neuropathy in our scenario. So the ocular toxicity of these systemic drugs can involve the anterior segment. For example, in this photograph, in the left-hand side, we can see a patient with vortex keratopathy in a patient taking hydroxychloroquine. But this was visually insignificant, and the patient could continue the drug without any side effects. And in the right-hand side, there is an angry-looking red eye with a patient with severe chemosis and sclerouveitis in a patient taking bisphosphonate, alendronate, which was used for osteoporosis. But even though it was looking so bad, it completely healed without any visual side effect after a week of discontinuation of drug and topical and systemic therapy. However, we are more worried about systemic drugs which affect the posterior segment, particularly the retina and the optic nerves, because they lead to more visually significant side effect and may lead to irreversible visual loss later on. So when we talk about drugs causing optic neuropathy, the optic neuropathy can be caused by various mechanisms. So let's first talk about the non-arthritic ischemic optic neuropathy-like mechanism. So the commonly implicated drugs which lead to ischemia of these optic nerves are the phosphodiesterase 5 inhibitors like the sildenafil, which is used for erectile dysfunction, and amiodarone. So it is most likely that these drugs cause some compromise in the blood flow of the optic nerve head, leading to ischemic damage of the optic nerve head. The other mechanism which leads to optic neuropathy is due to raised intracranial pressure. So because of these patients usually present with papilledema and transient vision loss, and the commonly implicated drugs in this group of toxicity are the oral contraceptives or hormone replacement therapies, patients who take tetracycline, corticosteroid, tamoxifen, and vitamin A. And the other group of drugs which cause the optic neuropathies are usually the drugs which call the mitochondrial optic neuropathies or acquired mitochondrial optic neuropathies. So these drugs may act by various mechanisms, but what they do is they affect the mitochondrial oxidative phosphorylation, leading to papillomacular bundle damage, leading to the terminology of toxic optic neuropathy. So the common drugs that we see in this group are the ethambutol, which causes retrobulbar neuritis. Basically, it's a metal chelator, and it chelates the heavy metals like the zinc and copper, leading to the interference with the mitochondrial pathways. Similarly, isoniazid is another cause, a rare cause of optic neuritis, and the exact mechanism is not known, but maybe it has something to do with the pyridoxine metabolism. The other drugs like methotrexate, they cause optic neuropathy probably because of folate deficiency. Then there's drugs like chloramphenicol and linezolid, which inhibit the protein synthesis, and mainly they affect the mitochondria, leading to optic neuritis, particularly retrobulbar optic neuritis in chloramphenicol, and sometimes it even leads to disc edema in case of linezolid. So the clinical presentation of all of these cases of toxic optic neuropathy are gradual, progressive, painless, and usually bilateral symmetrical vision loss affecting the central vision and causing central or secocentral scotoma because of the involvement of the papillomacular bundle. Depending upon the drug that we use, depending upon the severity and the chronicity of the disease, the optic nerve may be normal in the initial stages, or there may be edema in a few cases, and when it has it's in the advanced stage, it might lead to temporal pallor or even a pale disc. And all of these drugs are usually the withdrawal of the offending drug can lead to some improvement of vision, or at least there is a halt in the progression of the vision loss. So let's look at our experience of optic neuropathy at our center. So we had done a hospital-based prospective observational study where we tried to assess the ocular toxicity among patients taking antitubercular drug, where we followed up 45 cases of newly diagnosed patients of TB who were taking ATT for less than 1 month. So we did investigations like color vision, contrast, visual field, and OCT, and baseline visit, and followed these patients up for 6 months to see whether they developed optic neuropathy or not. So in our cohort of 45 patients, we found that only around 18% of the patients were receiving, who had severe extrapulmonary tuberculosis, had ethambutol for more than 2 months. The rest, 82% of the cases, had ethambutol for only 2 months. And the mean daily dose of ethambutol in these patients was 17.9 patients, 17.91 milligram per kg. And the mean duration of the ethambutol that they had taken was 2.7 plus minus 1.5, which is a relatively low dose and duration for patients taking ethambutol. And in this, in our study, we came across only one patient, which around 2.2% of cases had ATT-induced optic neuropathy. So the patient who developed optic neuropathy was a patient with broad spine who had received 6 months of ethambutol at a dose of 20 milligram per kg per day. And at the time of presentation, she had a history of 15 days of loss of vision. The visual acuity at that time was 636, and the color vision showed non-specific defect and the contrast had dropped to 1.75. At this time, the optic nerves fundus findings were normal, and the optic nerves looked pink, and there was no pallor at present. However, the visual fields showed, the Goldman visual field showed the classical secocentral scotoma in both of the eyes, and the VEP showed delayed latencies. However, at the same time, we were coming across many other patients of ethambutol toxicity. So during the same period of 2 years, we also were collecting other patients who had been who were not included in our study, but had been referred from elsewhere, who had a suspicion of optic neuropathy. So there were 14 patients of optic neuropathy, and all of these patients were the patients who had either severe extrapulmonary TB, who were under retreatment, or who had drug resistant tuberculosis. And the mean duration of ethambutol that they had received was for more than 7.25 months, and the mean dose was 18.27 milligram per kg. So we know that ethambutol is dose and duration related, and various studies have already proven that ethambutol given at a dose for more than 35 milligram can cause toxicity as high as 18%, whereas with a standard dose of 15 milligram per kg per day, the toxicity is less than 1% when given for more than 2 months. The government of Nepal has done a wonderful program of national TB control, where they are working very hard to reduce the incidence of TB. And to make the treatment easier, we have a standard protocol for patients who receive the TB treatment. We can see that depending upon the weight, the patients receive various doses of tablets. But in our study, what we found was patients who fell on the lower range of the, who fell on the lower ends of the weight band. For example, if the patient was 40 kg, he was receiving 3 tablets in comparison to a patient who was 39 kg who would receive only 2 tablets. So the patient who fell on the lower end of the weight band, they were had a higher risk of developing ethambutol-induced toxicity. And that also happened in a patient with TB who might be 40 kg initially when they started on ATT. But if the patient loses weight, and that is not calculated and taken into account. So we have to also make sure that the patient are receiving the correct doses according to the weight, even in spite of the dose weight fluctuation. Apart from that, we also came across one patient who had linezolid-induced optic neuropathy in this cohort of patient. So it was a patient with TB pleural effusion, and the patient was having intolerance to many drugs. So he had to stop most of the drugs. So the treating physician started this patient with ethambutol and linezolid for 9 months. So after 7 months of ethambutol, the patient started having deterioration of the vision, and ethambutol was stopped. But because there was no other option, linezolid was continued. And when the vision continued to deteriorate despite stopping ethambutol, linezolid was the patient was referred to our center. At the time of presentation, the visual acuity was counting fingers in both eyes, and the patient had bilateral temporal pallor. So we did MRI to find out if there were any other causes. Everything was normal. So we suspected this patient to have bilateral toxic optic neuropathy due to both linezolid as well as ethambutol. So this was at the time of presentation to our center. Now coming to the discussion part, though it is quite a common problem that we face, physicians are often not referring the patients to us in time, because of which most of these patients end with irreversible visual loss. So we need to identify the patients at risk, because we know that so many patients receive ATT and it might not be possible to monitor and follow up each of these patients. So we know that it is dose and duration related. So if we are able to find out the cohort of patients who are receiving ethambutol for a longer period, for example, severe extrapulmonary tuberculosis patients or drug-resistant tuberculosis patient, we might it might be easier and the patients might benefit from it. And in our part of the world, still antimicrobial therapy, particularly ATT toxic optic neuropathy, is more common than the other types of toxic neuropathy. And early diagnosis and stopping the offending drug is the only treatment at present. So I'd like to end my presentation with this slide. So to spread awareness of toxic optic neuropathy in our population. Thank you.
I think it's a wonderful presentation. So this awareness has to be really spread among the physicians. We've also seen a lot of patients of, though it is not very common in India, but we have seen patients of ethambutol toxicity in patients treated with ATT. Awareness is a key word. Yes. Thank you.
Sanchita,
Yes, ma'am.
because you've done this study, do you think that every patient, whoever, I don't know how much it is possible, that should we screen these patients to do a baseline contrast, color, and these investigations, and then they do it in mid, like once they do 1 month or 15 days, something like that? Would you like to recommend?
Ma'am, that was what I was trying to focus. We did the study, but because our population, we also included patients who were taking ethambutol for only 2 months. It proved not important at all, necessary for those patients. But we have to identify those patients where we give a longer duration of ethambutol, because we know that it is dose and duration related. So if we know that this patient is going to receive ethambutol for 6 months because he has pot spine or severe extrapulmonary TB, then it might be a good idea to screen those cohort of patients, maybe.
Yeah, I think because I remember one of our residents also had pot spine and he did had problem with his vision. And I think they had stopped him for ethambutol. So it is occurring even in medical students or something like that. So I think it's good, like you said, in that cohort, maybe we should tell them that we have these baseline investigations, because I think even for dry eyes and all, when we give this HCQ, hydroxychloroquine, even there we are having problems. So nowadays they have started sending these patients to do baseline investigations.
Yes, and most important is the patient should know that it might have this side effect, because mostly they are weak patients. They are either bedridden, and these patients with pot spine, and they are not able to move around so much. So they may not even be aware that they are losing vision. And sometimes most of our patients, when we tell them, why did you come so late? They tell that they were never counseled about it, and they thought it was maybe because of weakness due to TB that I'm seeing bad, and it might recover after I recover from TB, and that's what's holding them back from getting ophthalmological evaluation.
Yeah,
I think this is very important. Patient awareness of any decrease in vision, they should immediately report to an ophthalmologist.
Yes.
Dr. Sarita, are we going to do Dr. Raksha's video, or?
She's ready. She's ready.
Yeah, I think she
Dr.
was saying she's ready.
All right.
Dr. Raksha?
Hello.
Yeah.
Should I go ahead here?
Yes, Dr. Raksha, you can go ahead. But we do have a little time restriction, so a discussion may not happen. So you please go on with your video.
Hopefully, I'll be able to show. Is it visible now?
It's visible, but I think you need to start it now. Yes. Yeah.
Yeah, I've started the video.
No, it's not playing.
No?
No.
Probably you could go to the slides only.
Yeah, I think you can just finish with your slides. I think it's not working. Yeah, you can go from number 8 slide.
Yeah, but without video, it's so useless, to without the video, maybe video can the video be shared
To the back in IT people. Yeah.
Maybe you can tell us some pertinent points, because we are a little short of time as well.
Yeah, I know.
Yeah. Okay. So like, still, so like, okay, post Zepto phacoemulsification, you can see the capsulotomy is so well centered. It's right in the middle, like where you want it. And then it is perfectly round in shape, which covers the lens about 1 to 2 mm from the periphery. So it gives a perfectly sized capsulotomy following Zepto cataract surgery. And then now, what is the benefits of using a Zepto precision pulse capsulotomy? Is like you get a very predictable capsulotomy size of around 5.5 mm, and it can be used in use of complex cases such as intermittent white cataract. And it has been reported that there is less incidence of colored halos, glares, and ghost images you having this Zepto PPC. Patient with, it can be easily used in patient who have corneal opacity, small pupil, and who are one-eyed, so where you want a perfectly sized CCC. And in cataract in children. Also, it is recommended in patient with subluxated lens where already the zonules are so weak, like it's already weak, you don't want to do the manual CCC, then you can opt for the Zepto PPC because it will not put additional tension on the zonules. Or the calcified capsular, if you have a calcified capsular bag, even in those cases, it is useful and it is very safe. The safety features are, there are two designs that helps in the safety of this device. One is that application of energy is so less and it is only conformed to the microscopic edge of the nitinol ring so that it is not going to damage the other structures. And secondly, the nitinol rim, which has the electrical pulse, it is covered by the silicone cup, and further it is insulated by the viscoelastic devices, so like there's no injury to the ocular structures. And so to conclude, I would like to say that it is highly recommended for white intermittent cataract, brown cataract, corneal opacities, cataract with subluxated lens, cataracts in children, one-eyed patient, and in refractive IOLs. As you know, in toric IOLs, you would always want the CCT to be a round, circular, and of the exact size so that you can place it exactly in the axis where you want. And this perfectly shaped size of the CCC will give you the additional benefit. With this, I would like to end my presentation. Thank you.
Thank you, Dr. Raksha. Can I ask just one question? What is the cost of the Zepto tip and this machine? Like, can it be used again?
Zepto tip is like, I think it's around, in our hospital, like it will cost additional 30,000 to the patient, Nepalese rupees, for doing because the handpiece itself is just once a use, you cannot reuse it. So one use that capsule, but for the patient who really want it well, like that's why it's like, it's all depends on like whether the patient wants to go ahead with the Zepto or just the manual CCC.
All right, thank you. Are there any more questions for Dr. Raksha? We can go ahead with the next speaker.
Yeah, please. I think we are already short of time.
The next speaker, Dr. Rohan Chawla, is there with us. Dr.
Yes, I'm there. Yeah, I'm there.
So he's going to speak on the latest OCT and OCTA clinical applications.
Yeah. Thank you, Dr. Sarita. I'll just share my presentation. Can you see my presentation?
Yes.
Okay.
Just
so I'll just be talking about OCT and OCT angiography, and I think I'll go a little fast because we are short of time. So OCT, as we all know, is a non-invasive tool which gives us high resolution images. And now we have swept source OCT as well, which gives us a resolution of 1 micron. And even on-fast imaging is possible. So with this, we can evaluate not just the retina, but right from the vitreous up to the choroid, and even the sub-layers of the retina can be seen. OCT today is used not just for making diagnosis, but also for the complete management of the patient by deciding the line of treatment, whether it is surgical and medical, and also giving the prognosis to the patient. So this is a standard photograph of the OCT, which all of us who are dealing with retina must understand. These are the terminologies about each reflective and less reflective layer which have been given and which have been matched with the histopathology. So right from the retinal pigment epithelium to the internal limiting membrane, we can now identify almost each layer on the OCT. And of the photoreceptors, we can even identify the distinction between the outer segments and the inner segments and even the external limiting membrane. And all these are important in giving prognosis to the patient. So how do we describe the OCT? We should not just look at one image, but at multiple images and also compare with the fundus image. And then in the description, first look at how the foveal contour looks, then look at the status of each layer and sublayer, whether it is continuous or disrupted in any manner, and whether there is any abnormal reflective pattern in any of these layers. Then we can also comment on the gross central macular thickness in the 1 millimeter, 3 millimeter, and 6 millimeter zones. Then how does the vitreoretinal interface look like? And again, now with the advanced OCTs, we can even image the choroid, its thickness, and the nature of the vessels. So this is an example of an on-fast OCT where we have combined multiple OCTs, and this can even give us a very nice view of the extent of things like cystoid macular edema. This we have published in JAMA. Going further ahead, we can also do 3D reconstructions of these images and look at the choroid in a better manner. And here we have a myopic patient with this hypo lesion beneath the optic disc, which was confused by people as choroidal granuloma or a choroidal neovascular membrane. And when we did the OCT, we actually found that it is nothing but a cavity in the choroid. This is a choroidal cavern, and we've even published this. So one needs to distinguish these entities to prevent wrong treatment, like someone might have treated this with ATT or even given an anti-VEGF injection, but it is nothing but a choroidal cavern there. So OCT helps a lot in diagnosis these days. Now, what about OCT angiography? Now this is dye-less, and how does it work? So as the RBCs move in the vessels, the OCT signal which comes reflected back from them decorrelates, and analyzing this decorrelation of the OCT signal gives us the flow pattern. And without even injecting dye, the machine can give you the pattern of the vessels. So whatever moves, especially the RBCs, gives us the flow pattern and is seen as white, and whatever is static is black. So the flow pattern can be identified, and any new vascular tissue which has flow can be identified with this new technology without even injecting dye. So the important benefit is that we can segment the image of the OCT at various levels and analyze the vasculature at each level. So you can see the superficial retinal vasculature, you can see the deep retinal vasculature. Going further deep into the retina where there is no vasculature, you can even segment that area, and that should be seen as black, but any abnormal choroidal neovascular membrane there would be picked up. Then even deeper segmentation can give you an idea of the choroidal vessels. So what I was talking about is seen here, the segmentation. So you have the cuts, 4 cuts seen at the top, the superficial, deep, outer retina, and the choriocapillaries, and the B scan at the bottom left. So here you see these 2 orange lines. So this is the segmentation that is happening in this orange and superficial cut. So you have to ensure proper segmentation to know that actually what part of the retina are you analyzing for the flow. So just to give you an example of how these investigations have helped. Now this was a young patient with this sort of a fluid at the macula and a yellowish lesion there. So first impression was that maybe this is a CSC with maybe some fibrin there. An OCT scan was done. Again, this is showing subretinal fluid, and one can easily make a diagnosis of CSC looking at this. But like I said before, one should not just see one scan, one should see multiple scans. So if you see at another scan, now there are some atypical features happening here. You have intraretinal fluid as well as some abnormal hyperreflective material in the outer retina. So what is this? So the single investigation which we did was OCT angiography, and it has started showing us flow here in the outer retina as well as the choroidal slabs. So this is actually a choroidal neovascular membrane and an idiopathic choroidal neovascular membrane there, which is causing this fluid inside the retina as well as the subretinal fluid, and it is not a case of CSC, and this patient would merit an anti-VEGF injection. We have again published a lot on the analysis of idiopathic choroidal neovascular membranes using OCT angiography. Other clinical applications of OCT in dry age-related macular degeneration, OCT can easily pick up these deposits under the retinal pigment epithelium. In some cases, these deposits are above the retinal pigment epithelium and between the neurosensory retina and the retinal pigment epithelium. These are cases of pseudodrusen. So this can give us an idea of the extent of the age-related dry degeneration. So this, like I was saying earlier, is pseudodrusen, where again the fundus would show you those hypo dots, but the OCT confirms that the deposits here are actually above the retinal pigment epithelium rather than below it. Another example where along with this drusen, it is a sawtooth-like pattern where there are multiple of them, and you also have some hyporeflective spaces under the retina. This can be confused with subretinal fluid, but actually one needs to know this pathology. This is basically cuticular drusen with some vitelliform degeneration, and this patient does not merit an intravitreal anti-VEGF injection, but just follow-up. Another type of age-related macular degeneration is polypoidal choroidal vasculopathy, which can be picked up very nicely with ICG. So these lower ones are the ICG scans, where you can see these polyps being highlighted in this hyperfluorescent area, and a branching choroidal branching vascular network is seen below. Now, if you do not have ICG, still on OCT, you can have various clues which can suggest the diagnosis of PCV. So one of them is a double layer sign, where you see this retinal pigment epithelial line is being split from the Bruch's membrane. Normally, the RPE Bruch's is seen as a combined single line, but if it splits and there is a hyperreflectivity between them, it suggests that there is something there which might be a branching neovascular network if there is an associated pigment epithelial detachment along with it, especially a thumb-like PED. And this subretinal fluid indicates that this is an active membrane secreting fluid there. So a double layer sign with a thumb-like PED is highly suggestive of a PCV. And now recently a Singapore-based group has also talked of some hypolucent ring-like signs within this PED, which also suggest polyps. So the previous one, which I told you, is a thumb-like PED with a double layer sign, which is like a PCV. And there are another PEDs which are more trapezoidal in nature, and the hyperreflective material which could represent a choroidal neovascular membrane is above the PED, and most of the pathology is within the retina, intraretinal. So these are type 3 choroidal neovascular membranes or wrap-like lesions. So another clinical application where just you make the patient sit on one machine and you can have a diagnosis, and you don't need to have multiple machines and angiographies for the patient. So another patient where we had this hypo lesion at the macula with some hard exudates, once you did the OCT, you found that there is a double layer there with subretinal fluid. So again, you feel that maybe some neovascular element is there. You can confirm it with an angiography and an ICG, which will again show you the lacy network. But if you do not want to put the patient on a second machine and don't want to do an fluorescein angiography, the same machine do an OCT angiography, and even the OCT angiography will show you this nice network of choroidal neovascular membranes, and it tells you that this patient is again harboring a choroidal neovascular network, which is below the retinal pigment epithelium, so probably mostly a type 1 choroidal neovascular membrane, and again a candidate for anti-VEGF injection. On the other hand, this patient in the B scan, you can see the hyperreflective material with the red dots, which is the flow, is above the retinal pigment epithelium, and this patient has a type 2 choroidal neovascular membrane. We have even used this OCT angiography to guide us doing photodynamic therapy, although unfortunately now the PDT dye is not available. This swept source OCT is the penetration is so good that even in dense hemorrhage, dense subretinal hemorrhage, it can penetrate and give us images of what is underlying and where the blood is. Is it actually only in the subretinal space or also in the sub-RP space? And that can help us guide management, and in the form of intravitreal injection of gas and TPA. In this patient, we did inject with gas and TPA, and you can see that the blood has definitely reduced from the center of the fovea, and subsequently we treated this patient with further anti-VEGF injections and got some improvement in vision. So OCT has also been used to provide insights into retinal tumors. This is our publication on combined hamartoma, where we did OCT of many patients of these combined hamartoma, and we found actually that the retinal pigment epithelium is not at all disturbed. And we have proposed that this combined hamartoma is only probably a hamartoma of the retina and not of the retinal pigment epithelium, as its name says. Astrocytomas are other tumors which can rarely be seen and which have this typical mulberry sort of appearance, or just a sort of plaque in the inner retina is another form of astrocytoma. It has also good utility in cases of uveitis. So you have this patient of vitreous haze. The visibility is not very good, but again, swept source can penetrate and give you some idea. So in this swept source, we could see that the patient does not have so much of cystoid edema, but has these, again, elevations at the level of the retinal pigment epithelium with some deposits. And this was an elderly patient, so we took up for a vitreous biopsy, which confirmed B cells, lymphoma cells, and started treatment with intravitreal methotrexate. And following treatment, we can see the media is clearing. And now we can better appreciate these sub-RP deposits, which are probably because of the lymphoma cells. And with time, the height of these would reduce with intravitreal methotrexate therapy. Now, again, on a flat image of the fundus, it may not be very easy to tell where the lesion lies, whether it is subretinal or whether it is actually choroidal. So this patient had these yellowish lesion below this lower arcade. And once you do the OCT in one go, you can immediately tell that the entire lesion is choroidal. This hump there in the choroid there, and with some fluid happening under the retina. So this patient was cases of metastasis, and patient had lung carcinoma on CECT. Another case where you have this hypo lesion, these can be misdiagnosed as choroidal granulomas, tuberculomas, or other things, but OCT shows you that this has a lamellar pattern to it, and the lesion is not pushing the choroid or the retina up, but rather pushing the choroid downwards towards the sclera. And this is typically seen in cases of choroidal osteoma. Although if you have seen such cases, then the fundus picture itself is diagnostic, and you can also confirm with an ultrasound B scan. But otherwise, nowadays, you can also take the help of OCT to confirm the diagnosis of choroidal osteomas. Another choroidal tumor, choroidal hemangioma. Now here, as opposed to the other ones, here again there is a hump in the choroid, but you can see that there is some vascular pattern in the choroid still visible, and that is because of the vasculature of the choroidal hemangioma. And this hemangioma is again secreting fluid into the retina and below the retina and causing this intraretinal fluid and subretinal fluid. And we again do not have PDT now, so we just treat them with direct laser photocoagulation. And that, as you see here, we've done laser photocoagulation. The tumor stays, but there is significant reduction in the subretinal and intraretinal fluid, and the patient's vision stabilize. Though we may have to repeat this laser 2-3 times in a year, but many of these patients do stabilize. Again, in uveitis, it can also help us show cells in the vitreous cavity. We have also classified retinitis based on the OCT patterns of how it is, whether it is a plaque-shaped sort of retinitis or whether it is a chorioretinitis. I won't go into details again because of lack of time. So the second pattern of is toxoplasma retinitis, where it is more of a retinochoroiditis rather than just a retinitis. And this third pattern is where you get subretinal fluid and a macular star. This is post-fever retinitis. So a combination of the OCT pattern and the fundus image can help us classify some of these retinitis and guide us at least in empirical therapy before we get definitive investigations. This is one case of tuberculoma where you see a yellowish hump below the retina, and you see that there is some spillover of this inflammation into the retina above the RP. So this was a case where we strongly suspected tuberculoma, and patient also had lesions on the lung, and treated with ATT. And after ATT, you see there is such good resolution of the choroidal lesion. Unfortunately, the fovea of this patient was spared, so the patient did recover about 6/12 vision. On the other hand, this is more of a silent looking deposit in the choroid with a well-defined deposit and no spillover into the retina. This is more like a sarcoid granuloma. So these patients were treated with systemic steroids, and again, you see that granuloma is resolved. Although on the fundus, you still see that discoloration, but the OCT shows that the granuloma is resolved, and one can now taper the therapy accordingly. This is again a diagnostic dilemma in the fundus, where you see some maybe few granular yellow deposits at the posterior pole, and the patient's vision was reduced. So to make a diagnosis, one can take help of this multimodal imaging, fundus autofluorescence and fluorescein angiography. But again, they do not tell you much, maybe some hyperfluorescent deposits there. But the diagnosis immediately comes from OCT, where you can see there is no fluid, unlike CSR, there is no choroidal neovascular membrane, but there are these filiform vertical aggregates at the level of the RPE, and some loss of the ISOS junction. So in a young patient, this is very much suggestive of a multiple evanescent white dot syndrome, especially with that fundus picture and fluorescein angiography. Another young patient with recent loss of vision with hyperreflectivity under the fovea here. So again, one can do an OCTA scan here to be very sure that this is not a choroidal neovascular membrane. And if the OCTA does not show you a choroidal neovascular membrane, then the other differential here is acute pigment epitheliitis, which again responds to systemic steroids, or some people even don't treat it and it just improves in many cases on its own. Parafoveal telangiectasia is another entity where beautifully the superficial and the deep retinal cuts will show you the abnormal vasculature and pick up this entity, when the OCT will show you the lacunar loss of retinal tissue. It can even confirm the choroidal neovascular membrane in the deeper cuts in some of these patients. Even in diabetic patients where the disc may look normal, an OCTA through the disc can sometimes show you this neovascularization of the disc even without doing angiography, and then now this patient's diagnosis immediately changes into proliferative diabetic retinopathy. We now even have a montage or a larger frames of OCTA where we can pick up neovascularizations around the posterior pole, but still it is yet to evolve as much as an ultra wide field angiography. Although we do have a montage, but still the visibility of the peripheral or the mid peripheral retina is not there with this modality. So just, I think I would like to end here, and I'd just like to say that both OCTA and OCT angiography have given us a better understanding of the pathology of retinal diseases and the natural course and response to therapy. Thank you. Thank you very much.
I think it's a wonderful presentation, Dr. Rohan, and with such beautiful pictures. But because of short of time, I think we cannot go on to many questions. So we can discuss that later. Questions can be discussed later. So we go on to our next presentation. Dr. A.K. Dalal.
Yes, hello, good evening, ma'am. I'm here. I'll just share my screen.
Please. The technique of pterygium excision with conjunctival autograft, surgical pearls.
Yes, ma'am. Is my screen visible, ma'am?
It is visible.
All right. So a very good evening to all. I'll be talking about the technique of pterygium excision with conjunctival autograft. I'll be sharing a few surgical pearls that I have learned over the years. So first, let's talk about the goal of surgery. There are two main aims when we are looking at pterygium surgery: a good cosmetic outcome and minimizing the chances of recurrence. The surgery which meets both of these requirements is a conjunctival autograft. This was first described by Kenyon et al. In 1985. It gives us a good cosmetic result and has a low recurrence rate as well, although it can be very variable depending on the surgical expertise, and therefore we need to know how to do this surgery well. Let's look at a few preoperative concerns. The anesthesia for these patients can either be peribulbar or subtenance, depending on the comfort of the surgeon. We could either sit superiorly or temporally. I prefer sitting superiorly for all my pterygium cases. And instilling topical brimonidine 10 minutes before the surgery actually decreases the amount of bleeding intraoperatively, especially for those fleshy vascular pterygia. To understand the surgery and how to go ahead with it, we must know the parts of the pterygium. The head of the pterygium is the part which overlies the cornea. Then we have the body of the pterygium, which is overlying the conjunctiva. And the junction between these two is called the neck of the pterygium. So what we do is we strip the head off the corneal surface, we excise the neck, and then after that, it is very important that we dissect all of this degenerated tissue. This whitish appearance that we see is actually the elastotic degeneration responsible for formation of pterygium. So whenever we try to understand a surgery and perfect it, it helps if we break it down into the steps of the surgery and then try and understand how to master each and every step. So let's break down the pterygium surgery. The first step is excision of the head of the pterygium, followed by dissection of the subconjunctival tissue, harvesting the conjunctival autograft from the same eye, and then securing the graft in place. So I'll be going over all of these steps, and towards the end of my talk, I will be talking about the different techniques of securing the graft in position. So let's start with the first step, which is excision of the head of the pterygium. First, what we do here, as we can see in the first video, is we are stripping the head of the pterygium from the corneal surface and then excising the neck of the pterygium. Subsequently, the residual tissue is cleared off from the cornea using a number 15 blade. In the second video here, first we have undermined the neck of the pterygium, and then we have cut the neck of the pterygium, thus freeing the part of the pterygium which is on the cornea, and then stripped it off the corneal surface. So either of these techniques, whatever works well in your hands, is good enough. And what we must remember is that after stripping, there can be still some residual tissue remnant on the cornea, and that must be cleared off. And for this, a number 15 blade works really well because it is not too sharp and not too blunt. Now, sometimes we have these large adherent pterygia with significant underlying corneal scarring. And in these patients, very rarely, we might need to use a crescent knife. This video has been shared by Dr. Namrata Sharma, and we can see here that beautifully the use of crescent knife to dissect these cases. So here, in these cases, we have to be extra careful. As we know, the crescent is much sharper than a number 15 blade. We need to avoid a multiplanar dissection, as well as we need to make sure that we are not going too deep. Now let's talk about another important step of the surgery, which is harvesting the conjunctival autograft. So a few tips here is that when we are harvesting the graft, our aim is that the graft should be as thin as possible. And to achieve this, we have just made a small nick in the conjunctiva first. Then we are going in with our scissors closed and then opening the scissors as we go in so as to avoid buttonholing and also avoid the subconjunctival tissue in the graft. And so we use a combination of blunt as well as a sharp dissection techniques. We can see here that all the subconjunctival tissue is being dissected. Even after flipping the graft over, we can still dissect some of the remnant subconjunctival tissue which might be still present on the graft. So now let's look at the entire surgery. This, I will go through this a little faster because I have already discussed how to dissect it off the corneal surface. In this video, we will be concentrating on how to dissect the subconjunctival tissue and then securing the graft in place with the help of fibrin glue. So what we do here is that I am holding the conjunctiva, my assistant here is holding the tenons, and then again we go in with the conjunctival scissors using a combination of blunt and sharp dissection. So again, I'm going in with my scissors closed and opening my scissors as I go in to dissect all this degenerated tissue and then free it up from the underlying sclera as well once we have freed it up from the conjunctiva, and then excise all of this tissue all around. Make sure that we do not damage the medial rectus. If we have a doubt, we can always hook it. And then we go ahead and measure the defect that we have thus created after excising the subconjunctival tissue and the pterygium head. And then we can usually try to size the graft a little bit larger than that because it's easier to trim the graft rather than have a short graft and leave bare sclera. So again, I am trying here to not get any subconjunctival tissue, to have a graft as thin as possible, which opposes well and doesn't balloon up. We are using fibrin glue, both the fibrin and thrombin, fibrinogen and thrombin components separately in a 1 ml syringe mounted on a 26 gauge needle, and then secure the graft in position, ensuring the correct orientation, and then iron the graft out with McPherson's forceps. A very important step towards the end is to remove any overhanging tissue over the limbus. This greatly enhances the cosmetic outcome. And then trim the excess glue at the end of the surgery and then remove the speculum. Now let's talk about how can we secure the graft in position with the help of sutures. So here in this video, after removing the pterygium tissue, I'm using subconjunctival lignocaine to dissect the conjunctival autograft, which gives us a very nice plane. And we are using interrupted atovicral sutures, taking the episcleral bites to ensure a good apposition and avoid ballooning up of the graft. So typically what I do is I use 2 sutures on the limbal side at both the edges of the graft, secure it with the episclera as well as the host conjunctiva, and 3 to 4 sutures depending on the size of the graft on the conjunctival graft. And on the conjunctival side, these are all absorbable sutures and we do not need to remove them. So let's talk about the advantages of using fibrin glue over sutures. The main advantage is that it is a much faster surgery. The surgical time, as noted on a Cochrane review, was on an average 17 minutes less. Patient is much more comfortable and there are no suture-related complications. Now, surgical time especially becomes important when we are dealing with combined surgery, that is pterygium and cataract surgery in one stage, or we are looking at double-headed pterygia because this would require a lot of sutures. The main disadvantage of using fibrin glue is the cost. The fibrin glue is much more expensive. There's a very low level of evidence to suggest that there might be higher rate of graft dehiscence with glue versus sutures. But graft dehiscence, we must remember, is dependent on various factors, including the preparation of the graft, the manipulation of the graft, the surgical experience, and eye rubbing by the patient. So here, this is my last slide. I would like to talk about the surgical pearls on how to avoid complications, mainly graft dehiscence. So first and foremost is meticulous graft preparation. Try to keep your graft as thin as possible. If the graft is thin, it is less likely to get dislodged. It's less likely to get displaced or get ballooned up. We must dry the scleral bed before application of the fibrin glue so that we can achieve a thin layer of the glue. And a very important tip here is to use this fibrin glue, the fibrinogen and thrombin components separately in 2 1 ml syringes with a 27 gauge needle. What this does is that it gives us a very thin layer of glue instead of using the Diplojet injector, which actually causes clumping on the glue and can become very, very messy. So we need very little. We just need 1 or 2 drops of the glue. Then place the graft and then iron out the graft very well with 2 forceps. Use a McPherson's forceps and iron out the graft. An equally important step is trim the excess glue from the surface. We must dissect and cut the glue rather than pulling the glue because sometimes the glue might be stuck to the speculum and the graft can get dislodged when we pull the speculum out of the eye. And of course, we need to educate our patients to avoid eye rubbing post-operatively. Thank you so much for your kind attention. And before I end, I would like to thank all my mentors who have taught me this beautiful technique of pterygium surgery. Thank you.
A very wonderful presentation, Dr. Geda. The videos and very, very good.
Thank you, ma'am.
But we need to go ahead without any questions. But anything. So we go for the last speaker. Is it okay? Dr. Praful?
Yes, ma'am.
So we go on with your presentation, management of Descemet membrane detachment.
If my PPT is visible, ma'am?
Yes, it is visible.
Okay, so good afternoon, everyone. Thank you, AIOC and Nepal Ophthalmic Society for giving me this opportunity. So I'll be talking on a topic, Descemet membrane detachment. Myself, Dr. Praful, I am an associate professor at RP Center, AIMS, New Delhi. So this picture, this is just a picture of one of the patient referred to me. The patient had undergone cataract surgery 3 days before, and as per slit lamp examination, everything was fine except corneal edema. So I'll come to the video of this patient in my subsequent video. But remember, all such patients may be harboring some sort of DMD. Few words about the anatomy of Descemet membrane. We all know this is the innermost layer with thickness of around 8 to 15 micron, and it has 2 parts, mainly anterior banded and posterior non-banded layer. Most important part to remember is, remember the Descemet membrane is attached to stroma with an interfacial matrix, as I have highlighted in this arrow here, orange arrow. So this interfacial matrix, it consists of irregularly arranged collagen fibers along with some glycosaminoglycans. Why I am saying this point here is, if you leave a Descemet membrane detached for a long time, these glycosaminoglycan and hyaluronate, all that is important for adhesion, they are gradually degraded. So the adhesibility of the DM decreases as you delay the intervention of DM redetachment. Causes, we all know cataract is the most common cause, and there are other causes like PK, DALK, glaucoma surgery, and chemical injury. All this can cause, but most commonly it's seen in cataract, especially ECC cases where the incidence is almost up to 5%. With phaco, it ranges between 0.5 to 1%. Spontaneous DMD can occur, especially in cases of corneal endothelial dystrophies and as well as corneal ectasia. So risk factor, I'll not go through all the risk factor, but remember old age, endothelial dystrophy, hard cataract, and poor surgeon skill. These are the primary causes for DMD. During surgery intraoperatively, when you are using blunt instrument or the eye is little bit hypotenuse, you have given a peribulbar block and the pinky or the massage was given for a long time and there is hypotony, and when you are entering with your instruments or knives, if the globe doesn't offer that much resistance, then it's likely that you may land up in DMD. Post-operative, as I said, few cases there can be spontaneous DMD, most commonly FECD and keratoconus. Natural course, remember in all the surgeries, for example, in cataract, almost 1/3 of our patients, they have some sort of DMD, which may be localized to your MBR port or main port, but these are not visually significant. Self-resolution is usually the rule. However, in 5 to 10% of cases, this can be extensive, and all these cases, they need intervention. This is a paper which I published when I was doing a senior residence at RP Center. Here, the initiating point of this research was that most of our residents, when they are operating and they are writing on slit lamp and everything is fine. And when we did ASOCT, we could find some sort of DMD underneath the edematous cornea. So that was the point where we realized all such non-resolving corneal edema cases should undergo ASOCT. And this is the classification. Is basically a modification of macule classification to guide you how to plan. So basically, we classified DMD into superior inferior half or diffuse involvement of cornea. If superior inferior, then it can be further categorized as planar and non-planar, scrolled and non-scrolled. So I'll just show you a few pictures. Here you can see the DM is detached, but the distance is less than 1 mm. So we label this as planar. Anything more than 1 mm, as you can see, it's more than 1.1 mm from the stroma, it's a non-planar one. When the edges are rolled, it's known as a scroll DMD. If not rolled, then that's a non-scroll DMD. So based on that, we recommended this management guideline. Remember one thing, when the DMD is in superior half over cornea and it is planar edges, then you can simply get away with air injection. In all rest of the type of DMD, it's better to go for some sort of gas injection like SF6 or C3F8. So I'll just run through a few videos. This is one technique of attaching a DMD. As you can see, there is a diffuse DMD extending from the main port to the periphery. Here, the technique is simply you go in with a 30 gauge needle with C3F8 air, anything, then just keep on pushing the air to achieve a watertight chamber, airtight chamber. When the pressure is high, keep the eye for 8 to 10 minutes, and then you can remove few of the air. You can do some massage with a cotton swab or a Merocil spear, so that will help you in DM reattachment. This is a technique that I prefer. And in this, you can say it's a bimanual technique, because when you are injecting air and the patient is glaucoma or having some risk factor for optic nerve damage, you can damage the optic nerve. So here what I do, this is the same case which I said you that somebody referred me, suggesting that on slit line everything was fine, but you can see when I was using the microscope into OCT, there was diffuse DMD, but it was the cornea is too much edematous, so the surgeon might have missed that. So when you are dealing with such cases, what I do is I make two entries. One entry to balance my interchamber pressure, the other entry is to increase the intraocular pressure. You can see this is a 30 gauge needle. I'm going in, and preferably the site of entry is limbus or area where the DM is not detached, and this is another needle. So one of my needle is not having any syringe. It's an open hub that will regulate my IOP. The other needle is having a tuberculin syringe with C3F8 or SF6 or air, whatever I prefer. So when I'm injecting air into or gas into the interchamber, the other needle helps me to titrate my intraocular pressure, as you can see here. And after keeping the air gas for 8 to 10 minutes, you can burp it. And if your patient is having a PI, you can leave as much as you want. But if there is no PI and you haven't done a PI, it's better to leave the size of exactly how much the pupil is dilating, or 2/3 of the interchamber. And this massage, as I showed you, that usually helps you in taking care of the small permanent fold that might have formed. So this is another video. This is a case of fuchs endothelial dystrophy with advanced cataract. So I was planning 2-stage procedure. This was the first case. Phaco, I have already done the phaco. You can see the cornea, edematous, guttae, and folds there, and because of fuchs congenital endothelial dystrophy. But however, if you notice carefully in the main port here, there was some focal DMD. So such cases you can leave it like that, because ultimately you need a keratoplasty, or the other technique is fill the interchamber with air and burp the air through the main port or the port where the DM is detached. By doing so again and again, the folded DM will become unfolded, and then you can leave 2/3 air or C3F8 to avoid post-op detachment. This is a simple trick. At times, if the main wound is having a detachment which is extending too much, you can suture this side and do all this maneuver from other side. So remember, whatever the procedure that you prefer, explain the procedure to the patient, take consent if it is mandatory in your part of the country, and it's better to pilocarpinize to minimize the damage to lens or intraocular lenses. Anesthesia, you decide depending on the patient's pain tolerability. 29 or 30 gauge needle nowadays, people prefer that. Go through an area which is either free of DM detachment or limbal area. Complete airfill should be achieved, and wait there for 10 to 20 minutes. And after 10 to 20 minutes, you can see if the chances of redetachment is still there, then you can wait for more than that, or you can simply burp the air. In the end, I would advise you to dilate the pupil to avoid the complication of post-op pupillary block glaucoma. So I'm a corneal surgeon, so I do encounter such cases also. This was a case of PKP with detachment. As you can see here, the technique is same as you do post-cataract surgery DMD. However, here the cases are a little bit difficult because of the tricky graft-host junction. However, ultimately such cases also they get reattached. This is the last video I will show you. This was a case of DALK. Here it was a double trouble for me, because the DM was detached and the fluid was there between the Duas layer and stroma, as well as between the Duas layer and the DM membrane. So here I had to do initial technique is simply cut few suture and do some massage and inject the air, fill the interchamber completely with air. So the fluid that is there between the stroma and Duas layer will come out. But when the fluid is there between your DM and Duas layer, you have to give a short or a simple nick with a 30 gauge needle. As you can see here, the moment you do that, the Descemet membranes gets reattached. So this was the post-op picture of that patient. Sorry, I missed that. So these are other techniques that have been described by surgeons, like supra-Descemet air detachment, air drainage, or fluid drainage, and some people have even described DMEC for post-op DMDs. However, I haven't encountered such cases till now. With simple management like bimanual air bubble or gas injection, most of cases heals nicely. So with this, I'd like to conclude my talk. One last point: when you are dealing with a difficult patient, remember, while injecting C3F8, please counsel them that this gas is going to stay for 4 weeks, or else for next 4 weeks they will be after your life. Vision to nahi aaya. So with this, I would like to conclude here. Thank you for a patient hearing.
Thank you, Dr. Profula. It's a wonderful video session, and all the tips which you gave, especially the burping part, very nice. Even for anterior segment surgeons, it'll be good during cataract surgery. They can just put the air and a little burp, it will unscroll. Thank you very much. How much of C3F8 do you put? The percentage?
14%, ma'am.
14%. Okay.
Yes.
Okay, fine. And any more questions for any of the speakers we can take up? Dr. Roshija is there?
Yes, ma'am. Am I audible now?
Yes, you're audible now. So you can also go on with your presentation. I think there are no restrictions of time, so we can go on.
Yes, ma'am. I will. Is my screen visible now?
It is visible, Dr. Roshija.
Thank you, organizers, for the opportunity. Coming to the topic, diagnosing posterior uveitis, I think it's a big challenge for the clinicians to diagnose a case of posterior uveitis, but uveitis experts have sort of formulated an algorithm, and it helps us to arrive to a proper diagnosis of posterior uveitis. So whenever we see a patient of posterior uveitis, we need to ask few questions to ourselves. Is it choroiditis, retinitis, or retinochoroiditis? If there is involvement of retinal vessels, optic nerve head, and vitreous, whether it is infective or looking non-infective, whether the patient is immunocompetent or immunocompromised, whether it's a part of masquerade syndrome, whether the clinical picture is complication of ongoing disease or is it recurrence of really healed disease. We need to really differentiate the two and look for any association of systemic disease. Apart from all these questions, what is also very important is a very meticulous history taking in case of uveitis. That includes medical history, travel history to areas that are endemic to known causes of uveitis like tuberculosis. Age sometimes also gives clue to etiology of uveitis, like toxoplasmosis, syphilis, or CMV are known to have congenital transmission. Also, toxoplasmosis and toxocariasis are most common causes of infective uveitis in children. Herpes simplex in middle-aged patient with retinal necrosis, and varicella zoster in elderly patient for viral retinitis again. Durations of symptoms also kind of gives clue to the etiology. Like if the patient has viral retinal necrosis, the patient has very rapidly progressive loss of vision. Whereas in cases of toxoplasmosis or Behçet's, it would take 1 to 2 weeks after the onset of symptoms for the patient to go to a clinician. And fungal uveitis usually have very slow insidious process. Also, environmental triggers like exposure to cats hints towards ocular toxoplasmosis, exposure to cats for exposure to dogs for toxocariasis, tick bites, and Lyme disease. And also we need to see if the patient is immunocompromised or immunocompetent. In immunocompetent patient, ARN is usually secondary to herpes virus rather than other viral etiology, whereas in immunocompromised patient, varicella zoster, CMV retinitis can be thought of. So now we first come to retinitis. Retinitis has more chances of being infective. It can be focal or diffuse. Focal retinitis can have toxoplasma as reason. Also, Behçet's can have focal retinitis, but it is usually associated with some amount of vasculitis. Toxoplasma, usually what we see is headlight in the fog appearance. It will have very dense vitritis on top of a very bright yellow creamy lesion, like we see in the first picture. Whereas it can be diffuse retinitis, we can think of viral at first, and it can be very rarely secondary to toxoplasmosis. Now, in immunocompromised patients, we can think of CMV retinitis, but also the picture is very classic that has a lot of hemorrhages, granular necrosis, and amount of angiitis. Coming to choroiditis, choroiditis can be focal, like in TB and toxoplasma. Granuloma, like in TB, usually it is single, oval, hemorrhages and CNV on top of that granuloma. Sarcoid granulomas are usually multiple, can also have toxocara granuloma, can have an underlying foreign body, or also be fungal in origin. And if we see any definite pattern of choroiditis, then we have to think of white dot syndrome. So like I said, TB granuloma has a very typical picture, oval, single, and some amount of hemorrhage or CNVM can be top of all that lesion there. So next, coming to choroiditis, that is white dot syndrome. If the lesions are subtle, we can think of multiple evanescent white dot syndrome. If it is prominent, we can think of multifocal choroiditis. If the lesions are discrete, then we can think of Mew's punctate inner choroidopathy, multifocal choroiditis, or bloodshot chorioretinopathy. If the lesions are placoid, then we can think of APM, PPA, or serpiginous choroiditis. Now, serpiginous choroiditis is very common in our setup, and we need to differentiate between serpiginous and serpiginous-like choroiditis in these patients. Serpiginous choroiditis have larger placoid lesions. The lesions usually start from the disc, have autoimmune origin. These are usually non-TB and doesn't have vitritis as such. Whereas serpiginous-like choroiditis are usually infective, has TB as the cause. These are small placoid, starts from mid-periphery, and has vitritis and vasculitis along with the lesion. Now, apart from all these pictures that we see and come to a diagnosis, what also helps is investigations in these patients like color fundus photography, fundus fluorescent angiogram, and autofluorescence. Serial documentations helps us in documenting and monitoring the management of these diseases. In autofluorescence, there is diffuse halo of hyperautofluorescent throughout the lesions in active stage, which gradually becomes hypoautofluorescent along with mottling as the lesions heals. FFA usually has characteristic early hypofluorescence and late hyperfluorescence in active disease. And in Behçet's, there is usually a definite diffuse fawn-like capillary leak along with retinitis. ICG is not usually performed in our setup. However, it is usual where the lesions are deep choroid, has CNV or hemorrhage on top of the lesions, or in white dot syndromes. OCT is again very helpful. It helps on differentiate a lot of disease, including choroidal granuloma, masquerades, and a lot of diseases Dr. Rohan already has pointed out in his topic of OCT. USG also helps us to diagnose and document subretinal abscesses, granuloma, osteoma, and choroidal thickness. OCTA is useful for early detection and follow-up for CNVM. It is non-invasive tool for detecting activity. And these days, non-invasive technologies like fundus photography, OCT, autofluorescence, and OCT are better preferred than ICG and FFA for diagnosing any posterior segment diseases. But we also have to think that not everything that is yellow in the fundus is posterior uveitis. It could be exudative CSCR, the fibrin that is beneath the retina that looks like choroidal lesion. But doing FFA and OCT in these cases can really help us clear out what the pathology is. And also vitelliform lesion. It might look like multifocal choroiditis, but it is usually not the case. And we can perform autofluorescence and FFA in these cases as well, and differentiate between choroiditis and all these lesions. Apart from all these investigations, and if we think that it is still not conclusive, we can go for chest X-ray, HRCT, MON2, gold quantiferon, ACE, ELISA for toxoplasma, IgG, IgM, and RPR and TPH test. Yeah. Thank you so much for your attention, and sorry for all the delay that I made.
Thank you, Dr. Rashida. I think it was very short and sweet and very comprehensive.
Yeah.
So I think Dr. Pujari is already waiting. So I think we need to close our session. Dr. Meenu, Dr. Eli, thank you so much.
Thank you so much. Yeah, I think we should close. It was a very nice session. Thank you. Thank you all.
Thank you. Thank you to all the speakers and to all the participants. Thank you all.
Thank you.
Dr.
Thank you
Pujari,
so
you may please take over.
Hello.
Hello, hi, how are you?
Hi, I'm Chi Wai from Singapore Society of Ophthalmology. Prof. Anna Tan has to give a talk at Macular Society, so I will take over from her for now.
Okay, thank you.
So that I go ahead and introduce.
Yes. So good evening, everyone. Please welcome. So today will be a Singapore Society of Ophthalmology webinar will be there right now. So we have chairperson Professor Anna Tan and Dr. Harbans Lal, and co-chairperson we have Dr. Wang Sibai, and convener we have Dr. Namta Sharma and Dr. Rajesh Sinha, myself, Dr. Amar Puja as a moderator. So we'll begin with our first speaker. So Dr. Wang will be presenting, or like Dr.
I think we'll go by this order.
Okay.
Dr. Yap Zuli will be
presenting
first. Yeah. So Dr. Yap is a glaucoma surgeon at the Singapore National Eye Centre. Today, she and other speakers from Singapore, as well as India, will be presenting on the clinical applications of new ophthalmic innovations with a focus on surgical techniques, devices, as well as imaging. So we are very honored, and I'd like to thank AIOS for organizing this symposium in collaboration with the Singapore Society of Ophthalmology. Can I invite Dr. Yap to give the first talk on MIGS? Do the benefits outweigh the costs?
Hi, thanks so much. I'm just going to share.
Okay, are you able to see my screen? Hello?
Yes, we can.
Yeah, and you can hear me, right? Okay, hi, very good evening, everyone. Thank you so much for the invitation to speak. Hang on a second. Yeah, my name is Julia. I'm a consultant at Singapore National Eye Center, and I specialize in glaucoma and complex anterior segment surgery. So tonight I'm going to talk about whether the benefits outweigh the costs in minimally invasive glaucoma surgery. These are my financial disclosures. And so minimally invasive glaucoma surgery, stents and all the others have proliferated in recent years, so the market getting quite saturated. And ophthalmologists as a whole are quick to embrace new technology. But in our adoption, one vital question to ask is the benefits of new technology are really as large as we hope. I know not everyone here is a glaucoma specialist, so I'll briefly go over a few of the modalities available. So there are trabecular meshwork bypass stents, such as the eye stent, as well as the Hydrus, both of which I use quite regularly in my practice. Trabecular meshwork bypass by tissue excision, the Kahoot dual blade, the Omni Trab 360 trabectome, as well as the gonioscopy-assisted transluminal trabeculotomy, or the GATT. Aqueous outflow enhancement through Schlemm's canal, such as the Visco 360 Omni or Avin-Turner canaloplasty. Then there are suprachoroidal space devices such as CyPass, which, as most of us know, have been withdrawn from the market, as well as the iStent Super that's coming up. Blood-forming stents, such as the Zen implant, as well as the Presiflow microshunt, which previously was called InFocus microshunt. And then there's endocyclophotocoagulation, which reduces aqueous production. So benefits, it's easily and usually paired with phaco emulsification. Overall, it's safer than conventional surgery, such as trabeculectomy or glaucoma drainage devices. Overall, there's less chance of infection, hypotony, and all the tube-related complications, as well as astigmatism. Reduction in the medications, assuming it works as intended, it improves the quality of life as this reduction or even cessation of medication use. And the impact of this is manifold. It solves the problem of patient compliance, which varies widely and rarely, if ever, reaches 100%. It decreases long-term costs of chronic medication use, both to the user as well as to the taxpayer. There's less impact on the ocular surface, which our cornea colleagues are all too familiar with, and it also slows progression to a more severe state. There's also the matter of clinic visits. The follow-up for MIGS procedures much less intensive. It saves the patient the repeated clinic visits, as well as the attendant costs associated, such as taking time off work or the cost of actually attending the clinic. Whereas with the trabeculectomy, we often see the patients weekly for the first month. With phaco MIGS, we may see the patient maybe at day one, and then maybe at month one after the surgery, often skipping the in-between visits. There's, however, less adverse events doesn't mean no adverse events. And you find that with improper implantation, you get much poorer outcomes. So I've seen eye stents in the cornea, seen Hydrus stents dialing down, and some of them where the stent is mostly in the anterior chamber, leading to iris chafing or endothelial cell loss. And I personally would rather remove a stent than leave it in the incorrect position because it's not going to work and complication rates are much higher. With a blood-forming stent placed when they're too close to the cornea, again, corneal decompensation, or if they're not within the intended layer, then they don't work. And there are intraoperative complications such as Descemet membrane detachments, iridodialysis that I've seen before, and even a few reported cases of losing the eye stent within the eye and not being able to find it. With the tissue excision MIGS, they've also led to some significant bleeding and even 8-ball hyphemas, which then warrant or require an early return to the OT, and a washout would then be required. And in the minimally invasive blood-forming stents, such as the Zen and the Presiflow, fibrosis that occurs with any of these sometimes requires repeated needlings, revisions, and because of the conjunctival changes, it also precludes the later utilization of trabeculectomy, a tried and tested surgery. So this is a slide courtesy of my colleague, Professor Shamira Pereira. In the early days of MIGS, there was still a learning curve and insufficient evidence to make a case either for or against MIGS. It appeared that cost effectiveness wasn't really being met in most healthcare systems. But now that MIGS has been around for a much longer time and the IOP lowering effect has been proven in multiple studies, to varying degrees, we still need to ascertain if the overall benefits supersede the financial costs, that it is indeed more cost effective. We still, at the end of the day, whether or not the patient or the taxpayer, someone is paying for the intervention, and cost effectiveness is quite a system-specific issue. And then there's also the fact that it's time specific. So if you look at it at different time points, for example, at 1 year, the relative cost per millimeter of mercury IOP reduction was highest because it included both the surgical cost as well as the cost of post-surgical medications or anti-glaucoma medications that are required post-operatively. I think someone's not muted.
Doctor.
Sorry.
Ma'am, mute कर दीजिए नम्रता मैम.
Can we mute the speaker? Not the speaker, the person who is speaking right now.
Yeah, please go ahead.
Okay, so where was I? Oh yeah, so time specific. So I mean, if you look at different things, there was a study also shown in the US that SLTs was the most effective intervention at less than $100 per millimeter of mercury IOP lowering. And then there's GATT, which was the most effective MIGS procedure at about $400 per millimeter of mercury, and most expensive with the iStent phaco at $1,400 per millimeter of mercury. But again, that's at 1 year, and varying degrees of intervention that are used. And all those numbers change at different time points when you measure, say, 3, 5, 10, or 20 years down the line. They're also measurement specific, and there are now some indices that are widely adopted, such as the quality adjusted life years, QALYs accumulated, or incremental cost effectiveness ratios. So as I said, cost effectiveness is a highly system specific issue. So taking a look at the different systems, in Canada, for example, there was a study showing that 2 iStents were cost effective compared with standard of care glaucoma medications in patients with mild to moderate POAG for more than 15 years with QALYs gained. In New Zealand, again, the iStent with phaco was a reasonably cost effective intervention compared with topical glaucoma medications, especially if you're using more expensive topical glaucoma medications. And then in the UK, although it was more expensive, phaco iStent versus just treating the patients with glaucoma medications, it depends on what kind of medication. So you can see there's a big difference if the patient's using brand name eye drops. So it's only slightly more expensive versus if they're using generic eye drops where it's more than £100 per patient per year. And then in Germany, Hofer and Fosser showed that they had a study comparing phaco MIGS to cataract alone and cataract surgery alone, and found that in mild moderate POAG, it had the lowest cost per additional QALY gained, making it the preferred choice of treatment based on the cost utility criteria. In contrast, the marginal gain that you get if you're treating someone who's got advanced POAG, it may not sufficiently justify the additional investment. And in the USA, by Alexander and colleagues, that showed that there's about 1.9 billion annual direct medical expenses for glaucoma treatment, and then another 1.5 billion indirect expenses in the form of social security benefits, healthcare expenditures related to glaucoma-associated disabilities. So it's a huge cost to the system. At our center, SNEC, we currently have some studies that are in pre-publication looking at patient-related outcome measures, as well as measuring the cost to our healthcare system. And this can work out to be a little bit more for the public patient, but less if they are private patient, because it depends on how much the government's subsidizing, how much the patient themselves are paying, and how much they can claim from insurance as well. Then there's a fairly recent study that was published just last year, and it was done in the USA. And for this cost utility analysis in patients with mild to moderate POAG, the researchers used a Markov model to simulate glaucoma progression over a 35-year period through 4 stages of glaucoma, so mild, moderate, advanced, and severe, up to death in patients with visually significant cataract. So over 35 years, in the base case, you'll find that both the phaco MIGS arms cost less than $50,000 and gained more than 12.2 QALYs, compared to phaco alone, which cost almost $55,000 and gained just over 12 QALYs. And then, of course, medications alone cost about $58,000 and gained only 11.7 QALYs. So according to the study, the device arms dominator were much more cost effective when compared to surgery, cataract surgery alone, within 5 years. So MIGS is showing great promise. It's been proven to work within a certain subset of patients, and data is certainly looking quite optimistic around cost effectiveness. But we have a bit of a ways to go before we can be quite certain. There are still no alternatives. There's no magic bullet at this moment. Right now we just have medications, lasers such as SLT, and then traditional surgery. But it's something to consider moving forward. Thank you very much.
Thank you.
Thank you, Dr. Yap. Very interesting talk, and I see a lot of general ophthalmologists also placing in MIGS during cataract surgery, mainly to reduce reliance on eye drops. What do you think of this practice? Seems to be, you think it's cost effective? Is it safe? Is it
I think it's
something
fairly,
you would do?
Yeah, I think it's fairly safe. I think people need to be trained. Again, it just needs to be placed. We need to choose the correct patients that it will benefit, and it needs to be done properly. And like I said, if I see that the stent is not properly placed, I will take it out. I rather not have a stent in than have something that's improperly placed. With a lot of these trabecular bypass surgeries, you need to make sure that you do very good gonioscopy, both in the clinic and during the surgery. I do think, yes, that there's benefit, and I think it's great that non-glaucoma surgeons are using it, because glaucoma is everywhere and everyone's treating it. In general ophthalmologists will have to treat it. So I think it's great that people are, but it just has to be done well. I hope that we're doing a few more studies on improving the cost, like seeing whether or not the cost effectiveness is actually as beneficial as we think it is.
Thank you, Dr. Yang. We'll move on to the next speaker, Dr. Ong Hon Shing. Dr. Ong is a corneal consultant at the Singapore National Eye Centre, and he'll be talking about optical coherence tomography in corneal surgery.
Okay, you can see my slides.
Yeah, we can see it.
Yes.
Okay. Thanks, Chiwai. I'd like to thank SSO and the AIOS committee for the invitation to give this talk. I'll be going through some of the current applications, the use of OCT, and some of the future advancements in this technology in corneal surgery. So OCT was initially introduced using the time domain technology, where the reference mirror moves linearly over the eye, and multiple readings are generated to create individual A scans. An example of this is the Zeiss Stratus OCT, which can give scans rates of about 400 A scans per second with an axial resolution of 8 to 10 microns in the eye. By the end of the 1990s, technology moved to spectral domain OCT, which allowed a dramatic reduction in scan time by capturing the complete A scan data relative to a single focus point. And this is done without the mechanical scanning of the reference mirror, and it's using high-speed spectrometers instead. And this can achieve axial scanning speeds of over 25,000 A scans per second with an axial resolution of approximately 5 microns in the eye. And this is 65 times faster and approximately twice the resolution compared to the earlier time domain OCTs. So examples of these for anterior segments are the OptoView or RTView and the Cirrus HD OCT platforms. So I'll now show you some of the clinical applications of OCT in my practice when I manage corneal diseases. So this is a young patient with bad atopic keratoconjunctivitis. Due to uncontrolled inflammation, he suffered a corneal perforation, which required corneal gluing, as you can see. And after 6 months, the glue had fallen off, and the surface has healed, although there was still a significant thinning and scarring. So a deep anterior lamellar keratoplasty, or DALK, was planned for this patient. And for all my transplant patients, I perform an RTView to accurately evaluate the corneal thickness. And preoperatively, as you can see from this RTView image, that the thickness is about 200 microns. And this allows me to plan for surgery. And this is another patient with very poor ocular surface and neurotrophic keratopathy, which may be related to a chemotherapy. and her corneal thinning has progressed to a Descemet seal, as you can see on this RT view image, with thickness of only 44 microns. So this is a surgical video of the first patient who had corneal perforation with glue. So firstly, I mark the center of the cornea and place suture markers. Then I estimate the thickness of the cornea using an intraoperative ultrasound pachymetry. So intraoperative AS-OCT also allows me to assess which areas of the patient's corneas are thin. And also we use the Henner trephine to make the initial trephination of the cornea. And then I proceed to take the various layers of the cornea off. So using intraoperative OCT, I know that this area of the cornea is, the central area is relatively thin, and this is the area where there was the original perforation which needed gluing. So I avoided these areas and left this area untouched until the end. So there's a marginal dissector which allows blunt dissection of the deep corneal stroma. But unfortunately, at one point, I gone slightly too deep and resulting a micro perforation, as you can see, with a leak of aqueous with the corneal scissors. And I immediately injected air in the AC and continued the dissection. So this is shows that I've reached the desired depth of 60 microns and ready to place my graft on. So to get good vision in bulk, I try to aim for residual thickness of sub 100 microns, and this is a good depth. I've left the central area thin, as I mentioned earlier, to take off at the end, which I expect to have a hole due to previous perforation. So similarly, I injected air into the AC, and I was able to use residual stroma to tamponade the microperforation. And given that there's 2 microperforations in this case, the risk of postoperative double AC is high. So, this intraoperative OCT allows me to assess whether there's any posterior lamellar detachment to avoid a postoperative double AC. This is postoperatively showing a clear corneal dog graft, and RT view AS-OCT shows full attachment of the Descemet membrane despite the 2 microperforations. This is another patient with an almost opaque cornea, as you can see, due to severe bullous keratopathy. She had a previous penetrating keratoplasty followed by a DSEC under this PK, and she underwent multiple glaucoma surgeries. And you can see a severely swollen cornea on this RT view image with measurements of over 1,000 microns. And you can see actually her old Descemet graft underneath, which is also quite swollen and starting to detach from her penetrating keratoplasty. So I plan to change her DSEC graft. So this is her surgical video. So the intraoperative AS-OCT is very helpful in these circumstances where the view of the anterior chamber is limited, and you can see how opaque the cornea is. Sometimes by removing the epithelium, you can see you can improve the view, but you can see this view is still quite limited. So for I normally go through a 4.5 millimeter scleral incision, but for her, I did a limbo tunnel incision because of previous glaucoma surgeries where her conjunctiva and sclera is quite scarred. So I'm using a reverse Hinsky hook and also a forceps to remove her old DSEC graft under her original PK, and this is a 23 gauge forceps to explant the graft. So this is her old DSEC graft that you saw on the RT view image preoperatively. So from the OCT images, I'm able to assess the posterior graft host junction, which is helpful in sizing of the DSEC graft. And also I can see that there's not much PAS, which need to be released before graft insertion, which is difficult to visualize because of extremely swollen cornea. So this is graft insertion using the endoglide. And in these cases of limited view, normally I stain my DSEC grafts. I normally don't stain my DSEC graft, but I stain in these cases of opaque corneas with trypan glue to give a better visualization. So this is after air tamponade, and you can see intraoperative OCT showing the attachment, the DSEC graft is fully attached at the end of the surgery. This is following a full air tamponade. So post-op, her DSEC graft is fully attached, and you can see that her cornea is relatively clear even at day 1 compared to her opaque corneas preoperatively. And her edema has improved markedly with the newly transplanted functioning endothelial cells. One of the difficulties, so moving on to DMAC, one of the difficulties of DMAC is graft orientation following insertion to the eye. And this different OCT platform is the Leica and Focus intraoperative OCT, which allows continuous monitoring, unlike the Zeiss OCT. So intraoperatively, by assessing the direction of the DMAC scroll on the OCT, the orientation of the graft can be assessed, as the DMAC has a tendency to scroll endothelium outwards. So you can see at the end of surgery, on the AS-OCT, the DMAC graft is fully attached before we close up. So how about in the field of translational research? So this is something that we've been working on in CERI, our Eye Research Institute, and this is a surgical video of cultivated human corneal endothelial cell injection therapy on rabbits. So a silicon tip cannula was used to scrape the Descemet's membrane to remove all rabbit corneal endothelial cells. Trypan blue was used to assess the areas of Descemet's membrane that's denuded of corneal endothelial, which stains blue. And then cultivated cells injected. You can see that the injection of the cells through the OCT. So we showed significant clearing of the cornea in rabbits that received the cultivated cells compared to controls. And this is the use of the ArchiView OCT, showing that the corneal thickness, which corresponds to the distribution of the cells that you can see on this electron microscopy, is thinner compared to the areas where there was no injected cells. So, and we think that even on the OCT, we can see some of the cells that are visible on the posterior cornea. So having seen some of the practical applications of anterior segment OCT, so what next? So current AS-OCT of the human cornea can give best resolution of, as I mentioned earlier, about 5 microns. And even with the with RTView, where we still cannot identify the cornea layers directly. So one of the more recent advances in OCT technology is the introduction of ultra high resolution, or UHR OCT. And they've been used to visualize things like blood cells, including leukocytes and platelets. And this is the use of a micro UHR OCT with the resolution of under 1 micron to render histology-like images of the corneal endothelium. And it's comparable, as you can see, to IVCM, which is in vivo confocal microscopy, and SEM, which is scanning electron microscopy. So UHR OCT has demonstrated the capability of distinguishing corneal nerves and also things like limboepithelial stem cells. But UHR OCT are currently still limited to academic institutions, and more user-friendly and commercially available platforms should be the next step in the development of OCT. So that's my 10 minutes. So I'd like to thank Prof. Job Matters for some of the contents in this talk, and thank you very much for listening.
Thank you, Dr. Ong. Very good talk, and always great to see a good surgical technique in combination with advanced imaging to improve outcomes for patients. So I will give the next talk. Let me share my screen. So I'll be talking about spectral domain OCT versus swept source OCT. We'll touch on some of the facts and misconceptions about swept source versus spectral domain technology. So optical coherence tomography is a technique for obtaining subsurface images of translucent or opaque materials at a resolution that is equivalent to a low power microscope. OCT has become a standard of care in ophthalmology, as you can see in all the previous talks, whether it's cornea or retina or glaucoma, providing real-time information to diagnose disease, evaluate progression, and also to assess response to therapy, which helps us to understand more about disease pathogenesis and in turn enable the creation of new novel therapies. So this is an interesting image on the right side, which shows the first in vivo image of the retina at 15 micron axial resolution, which was performed at MIT in 1993. So Dr. Ong has also touched a bit on this, and I'd just like to emphasize that OCT has actually undergone a lot of improvements in the past 3 decades. The first time domain OCTs in the 1990s, they were only able to manage 100 scans per second and 10 microns of axial resolution. And only in the early 2000s, with the introduction of the SS-OCT 3, that the imaging modality OCT started to gain more traction. Fast forward to today, we have Fourier domain OCTs, which are the spectral domain and the swept source OCT. Both are now capable of 1,000 times the scan speed at much higher axial resolution than the original time domain OCTs. In terms of the technical parameters of interest, there are some differences between the two. And the main difference is in the wavelength that's employed. 850 nanometers in spectral domain and a longer 1050 nanometers in swept source. The imaging depth is slightly longer for swept source, and there is also less sensitivity decay, which we know more commonly as sensitivity roll-off compared to spectral domain. Scan speeds are actually similar between the two, and currently commercially available machines can achieve 100,000 scans per second for both technologies. The axial resolution is actually higher for spectral domain at 5 microns compared to 8 microns in swept source. In terms of cost, swept source is still much more costly than spectral domain. Now that we have an idea of the technical differences, the critical question is whether swept source offers diagnostically relevant advantages relative to spectral domain. And we'll answer this question today by looking at the clinical differences between the two and also addressing some misconceptions. So myth number one is that swept source is faster than spectral domain. And although spectral domain may have started out slower at 25,000 scans per second, they have since caught up with swept source, and now both can perform 100,000 scans per second. The patient experience is great for both, less than a second to obtain a scan of the macula. For OCT and geography, the experience was actually better with the spectral domain, taking about 10 seconds compared to almost 50 seconds with the swept source instrument. Myth number two, spectral domain is not a good tool for assessing the choroid. Swept source, by virtue of the longer wavelength, has a natural advantage for imaging below the retinal pigment epithelium. But with enhanced depth imaging, or EDI, using spectral domain is also a great way of visualizing the choroid. So in this study, the authors compared spectral domain with EDI versus swept source OCT, and they found that both modalities were able to image the choreo-scleral boundary in more than 90% of the eyes, with the swept source performing slightly better in terms of the sharpness of choroidal structures. But the interdigitation zone was clearly visualized with both instruments. These are the representative scans with the EDI SD-OCT and the swept source OCT. You can see that the choroid as well as the choreo-scleral boundaries are well visualized with both modalities. These are the important structures that we look at on a day-to-day basis for disease diagnosis and monitoring treatment response, and these can be visualized equally well with both instruments. Myth number three, swept source is better for visualizing the vitreous. The ability to visualize the vitreous is a function of the wavelength of light used. So in this study, the authors compared two wavelengths, essentially spectral domain versus swept source wavelengths, in terms of their ability to image the vitreous and the vitreoretinal interface. So these are images which show a decreased ability to visualize vitreoretinal adhesion with addition of EDI. And use of longer wavelength OCT, vitreoretinal adhesion was clearest with the 870 nanometers without the EDI. So here, SD-OCT appears to have the clear advantage, although with some swept source OCT devices, there is software-enabled enhanced vitreous visualization mode to improve contrast of the vitreous. Myth number four, swept source OCT is better for glaucoma assessment. In this study, spectral domain was compared with swept source for evaluating the macular inner retinal layers for glaucoma diagnosis. And the authors actually found that spectral domain was potentially superior to swept source in detecting GCIPL thinning in the outer temporal zone, where glaucomatous damage predominantly occurs. This was attributed to the higher axial resolution, which we talked about in the past slides, of SD-OCT, which enables the more accurate segmentation of inner retinal layers, thereby improving the detectability of thinner retinal layers. Myth number 5, sweat source is better for eyes with hazy media. The longer wavelength of sweat source does improve penetration through dense ocular media, as I think most of us would have found in our clinical practice. And I also found it useful to image patients with dense cataracts using sweat source compared to the spectral domain. Another advantage of sweat source I found was in the visualization of the macula in gas-filled eyes. So in this study, the eyes were imaged after macular hole surgery with gas tamponade. And a clear benefit of sweat source can be seen in the first 3 days of the surgery, where a significantly greater proportion of eyes where visualization of the macula could be performed using the sweat source compared to spectral domain. But by day 7, this difference has diminished. These are the representative images. On top is a pre-op scan of the macular hole, followed by volume and line scans taken with the spectral domain and the sweat source respectively, which shows better visualization of the macular structures using sweat source. On the right are images from 2 of my patients, and I found that I can get quite a good look at the fovea on post-op day 1 using sweat source OCT most of the time, and less often with spectral domain, where I often get grainy images instead. Myth number 6, sweat source OCT can capture wider scans than spectral domain. And we have discussed previously that technical differences between spectral domain and sweat source, these are not limiting factors for scan width. So both instruments are actually capable of capturing wide scans. Commercially available OCTs can now scan up to 12 millimeters. I think this has become the standard, while the Plex Elite sweat source OCT can even capture up to 16 millimeters. Myth number 7, high myopes can only be imaged with sweat source OCT. Sweat source OCT with the greater scan depth and lower sensitivity roll off with that does have certain advantages for imaging very high myopes. I have also found the sweat source to be more useful in patients with deep posterior cephaloma when I want to have a broad view of pathology in relation to the posterior cephaloma walls, such as in the images shown on the left side here. I also find sweat source OCT to be useful in patients with macular hole retinal detachment, because with the greater scan depth, it's easier to search for the macular hole in detached retina. On the other hand, I prefer to image localized pathology like myopic CMV and foveal schisis using spectral domain OCT because of the higher axial resolution, which makes it easier to look for progression as well as response to treatment. Images on the right are from spectral domain OCT in a 29 millimeters eye, and it's good enough to look at the area of interest. There are also other practical considerations before we decide which is better. And the first is cost. And for now, sweat source OCTs are still much more expensive than spectral domain. Normative data with spectral domain is also much better established compared to sweat source. So the comparability of longitudinal data is a very important factor to consider when you switch imaging modalities, especially for predominantly glaucoma and retina-based practices. And lastly, your patient profiles will determine whether sweat source will actually be an useful addition to your imaging armamentarium. And as we have mentioned, in high myopes, patients with dense media opacity, as well as choroidal pathology, if majority of the patients are of this profile, then you will definitely benefit from having a sweat source OCT in your practice. So in conclusion, while I think that sweat source does confer some benefits over spectral domain, the clinical benefits may still not be justified in swapping out your spectral domain for the sweat source OCT. The incremental diagnostic utility is perhaps not there yet for glaucoma assessment, visualizing the vitreous or assessment of the retinal vasculature. But as both technologies continue to improve and mature, we may see a greater differentiation between the two for specific clinical situations in the future. So sweat source and spectral domain both can be useful in your daily clinical practice. For now, I do believe that spectral domain will continue to be a cornerstone in our day-to-day clinical practice. Thank you very much.
Thank you, Dr. Wang. That was a wonderful presentation. So we have next speakers, Professor Rajesh Sinha. I think he is not there. And we have Dr. Harbans Lal. I think he's also not there.
Sir, we have the video of Dr. Petrina, recorded video.
Okay.
Yes. So Dr. Pterygium Tan will not be able to join us today, but she has kindly recorded a video of a talk on orbital trauma, looking into the future. So we can play the video now.
Dr. Wang. Okay. Okay, they are playing. Okay, that is fine.
Good evening all, I am Petrina and I am grateful for this opportunity to be involved in this All India Ophthalmic Symposium. So today my topic will be on orbital trauma looking into the future, and in particular I'll be focusing on orbital-facial trauma for this talk. As an orbital-facial surgeon, the goal when I'm faced with cranial-maxillofacial trauma is to restore form and function of all structures of the face with complete healing and no complications. Maxillofacial fractures and reconstructions can be challenging with potential morbidity even in the best of hands. However, technology has complemented techniques in achieving more ideal outcomes in fracture repair than in the past. So new techniques include minimally invasive surgery with tissue preservation and minimal normal tissue disruption. Technology in the form of computer-assisted navigation surgery includes the use of DICOM data to virtually plan resections and reconstructions, customize implants, allow us precision in intraoperative localization and in implant placement. We have also made headway in orbital implants now with different kinds on the market. You have bioresorbable implants, standard and pre-bend anatomical implants, and even patient-specific implants. I am very fortunate to have the support of a multidisciplinary team in the hospital when dealing with maxillofacial fractures. And by and large, we perform fracture reduction with computer-assisted navigation, much akin to GPS system we use to drive today. And these are the steps. First, we have a diagnosis based on the clinical findings and 3D imaging. There is preoperative planning, intraoperative navigation, and postoperative imaging and validation. The first step is to acquire CT images with cuts of 1 mm or less saved under an image guidance surgery IGS protocol. The next step is segmentation, where the cortical outline of the orbital-facial bones of the unaffected side is manually outlined and verified in the coronal, axial, and sagittal views for accuracy, and images are saved. The outline of the normal orbit and facial anatomy is then mirrored to the contralateral affected orbit and face, which will show the discrepancy between the normal outline and the disrupted bony outline. This data is then transferred to the navigation system for use operatively. Virtual computer-assisted planning and simulation of a facial and orbital reconstruction can also be performed on the basis of 3D data sets preoperatively in order to increase the predictability of the desired outcome and safety of the surgical procedure. The objective of surgical planning is to create a virtual model that matches the desired outcome of the surgery. The planning software that has been developed for this purpose also allows for threshold-based segmentation and/or even atlas-based automatic segmentation during the process of creating such a virtual model. In the future, atlas-based automatic molding and deformation will more and more replace the procedure like mirroring, rotation, and manual deformation of virtual orbits, and will lead to more precise and especially quicker planning procedures. STL datasets or 3D bodies can be imported into planning software so that standard implants, anatomically preformed implants, and patient-specific implants can be virtually positioned in the patient dataset preoperatively, and the shape, size, and fit can be assessed. STL datasets can also be exported so that virtually generated models, reconstructions can be produced by 3D printing and allow patient-specific models to be created. And such models can be used to adapt and preoperatively bend patient-specific implants for reconstruction. At the start of surgery, the patient must be fused with the image data set displayed on the screen, and this process is known as referencing. The patient position must be registered and is accomplished by using a reference array or tracker. Depending on the navigation system used, a reference array or a tracker is fixed to the cranial vault or forehead respectively. And I routinely use the Brain Lab system, which depends on optical tracking systems rather than electromagnetic systems. So we use registration, we register using the bony landmarks. And once the technical requirements are met, the position of the pointer tip can be visualized in the dataset on the navigation screen. And this then allows us to determine our limits and safety zones of dissection as well as verify realignment of bony fragments. Intraoperative navigation also allows us to confirm that the implant is placed in the correct position with adequate support around. As the oculoplastic surgeon, I find this very useful in large orbital floor fractures or secondary fracture repairs, where the posterior ledge may not be easily visualized and thus the pointer of the tip represented by the crosshairs as seen in the last picture below can help me. I'm going to deviate a little now from computer-assisted navigation surgery to mention about orbital implants and the changes we have seen in the past and what we can expect in the future. This is a paper published by our esteemed colleagues from NUH about their experience with the different orbital implants they have used in the last 10 years. Certainly not one size fits all, and different implants and dimensions work well for different fractures. These are some examples of permanent implants, titanium mesh, and technology has also allowed us to prefabricate patient-specific implants or even pre-bend prefabricated implants. This is another paper about pre-bending prefab implants using the angle of inferior medial orbital strut of the non-fractured orbit to achieve better outcomes. And another group who has used PSI and intraoperative navigation to achieve good results. We have also seen more bioresorbable implants in the market thus far. The first bioresorbable implant would be our autologous bone graft, but the disadvantages of that includes local donor bone morbidity and the lack of pliability. Bioresorbable implants have been used in reconstruction of orbital defects and various maxillofacial fractures with their advantages. So this is a patient who had fracture repair elsewhere but still had residual significant left inophthalmos. She was seen for her secondary fracture repair NUH, and with the help of those at the Osteopore Company, we fabricated a patient model, an implant sample, and we made a patient-specific implant and placed it in the patient. So this is a post-op scan where you can see that the implants, which is represented by this hypodense area, is in good placement, and we have a very happy patient. There's another patient who was assaulted and sustained left orbital trauma, and preoperatively he had significant diplopia with limitation of adduction. The pre-op coronal fractures show a fracture of the orbital floor and the lateral and anterior wall of the maxillary sinus. He had restriction of the left eye in the up gaze, down, and adduction with significant diplopia on left gaze. So using navigational surgery, we perform fracture repair to localize the defect, the posterior ledge, as well as placing the implant. Postoperatively, this was his scans with the implant in good placement on orbital floor and the return of his eye movements to normal. So along with minimally invasive techniques, newer implants and the use of intraoperative endoscopy, navigational surgery has been one of the greatest advances in orbital and facial reconstruction. So what does the future hold for us? Navigational surgery can be further improved upon having an easier setup, less invasive referencing, more accurate auto-segmentation eliminating the human factor, possible standard age, race, gender patient templates for patients with bilateral injuries. Intraoperative imaging in the form of mobile cone beam CT scans like over here will give low-dose radiation and provide real-time imaging and biofeedback while we are operating. And with that, I thank you. Good evening all, I am Petrina and I am grateful for this opportunity to be involved in this All India Ophthalmic Symposium.
Oh, okay, great. Thank you for the very interesting talk. I think I'll hand over to you for the next segment.
Yeah, the next speaker is Professor Rajesh Sinha. So the backup team, do you have any video or Rajesh sir is here? I think he is not there. We'll go ahead with the next presentation. Next presentation is Dr. Harbans Lal. Sir is here. Sir, can you hear me? Dr. Harbans Lal? Okay, he might be busy with some of his work. So I'm the next speaker. I'll present my slides. Is my slide visible? Dr. Wang, is my slide visible?
Yes.
Yeah, thank you. Good evening, everyone. So I'll be presenting on surgical training in wet lab. So the ophthalmology training consists of theoretical teaching as well as surgical training, and the surgical training initially begins in the wet labs. So here we are going to teach the basic steps to the residents and the trainees, and then we are going to demonstrate the surgeries in real actual OT rooms. Then we are going to give the cases. So at our National Eye Center in RP Center, AIMS, New Delhi, we have virtual simulators as well as we train on animal eyes. So this is an IC simulator for cataract, which is basically used. So it's like a video game. Majority of the residents are going to learn how to do the continuous curvilinear capsular axis. Also, they are going to learn how to chop the nucleus and how to use the phacoemulsification for cataract surgery. Because cataract surgery is one of the most commonly performed surgeries, and every residency training begins with cataract surgery. But as far as like artificial modules are concerned, they are very unrealistic, and they are going to give a sort of video game sort of feeling. The real tissue interaction, the hand and memory, this thing. So that is not imparted by the video games or the IC simulator. That is a major drawback. We are not going to touch the real cornea. We are not going to feel the vitreous loss. The lens nucleus is not going to be as real as human eyes. So we have close neighbors, that is animal eyes, which are like quite similar to human eyes, but they have different tissue elasticity and other features. But they are going to be a very close this thing. So here I'm going to tell some of the things which we followed our National Eye Center. So whenever we bring animal eyes, specifically we bring more of a goat eyes. So they are going to cost 4 pieces for $1. We are going to inspect the globe, whether globe is intact or not, and whether it's having any sort of injury. So the one which are not having an injury, we are going to inspect them. We are going to identify the landmarks, including the big equator and the limbus. Once the intraocular tension is quite, negotiables, then we are going to wrap the globes. So this is how we are going to wrap for like corneal surgeries, iris surgeries, and the cataract surgeries. So here, around 2 or 3 millimeters of the antisclera is visible along the cornea. And this is a cross-sectional view, which shows that how to wrap the globe using a gauze phase for anti-segment surgeries. So similarly, for glaucoma surgeries, we are going to slant because we are interested more in the limbus, sclera, as well as some part of the cornea. So by tilting the globe forward, we are going to wrap the globe. We want to have the exposure of the sclera as well as the limbus. So this is how we are going to wrap for the glaucoma surgeries. After that, for squint surgeries, we are going to identify the extraocular muscles, which are having sufficient length up to 10 to 15 millimeter. And the one recti which is having very close resemblance with the human insertion. So we are going to identify that rectus and we are going to wrap along the cornea. So this is how we are going to wrap the globe so that the muscle should be at the apical region. So after this one, we are going to mount these eyes on the mannequin heads, corneal, and the cataract surgeries. This is how we are going to mount, and we are going to rotate the cornea. So depending on the superior or the temporal surgeon's preference, we are going to rotate the clear portion in that direction, and we are going to teach the surgery. For glaucoma, as I previously said, after wrapping, we are going to tilt the globe anteriorly so that the limbus, sclera, as well as some part of the peripheral cornea is quite clearly visible. For squint surgeries, we are going to put the wrapped globe inside that mannequin head orbit. And after that, we are going to suture the free end of the muscle so that just to simulate the resting tension within the muscle, we are going to attach this one to the neighboring strand. So for cataract surgery is concerned, there are so many modules which are being used. So in our setup, we use, apart from IC simulator, we have a goat size, which we bring at least 20 to 25 pieces per day. We have a residency strength of 150. So here, after bringing the goat eyes, which are qualifying our criteria, we are going to keep these eyes in oven, so for 5 to 6 seconds. So that's how the nucleus becomes hardened. And on the left side, you can see we are teaching the small incision cataract surgery. On the right side, you can see we are teaching them phacoemulsification. So in addition, we are going to teach them how to put the IOL in the bag, in the sulcus. On the left side, you can see the IOL has been placed in the antechamber. So in the middle diagram, you can see that some residents who are dedicated refractive surgeons as well as IOL surgeons, they want to simulate the SFL surgery. Here, we are going to use additional multi-piece haptic to join the original multi-piece IOL, so that because the corneal diameter, the least diameter is around 15 millimeter in the goat eye. So after this one, we are going to increase the length of the haptic, and we are going to make side pockets, how to stuck the haptics in the scleral pockets, and that's how we are going to give an orientation regarding how to do SFL surgery. On the right side, you can see that we are going to get an example of square-edged IOL, and that's how we are going to simulate the ICL surgery, how to lead the, how to tuck the leading haptic and the rear haptic. So in addition, we have systematic protocols where using Oscar scoring system, we are going to grade all these surgeries. So we begin from simplest surgery to the complex surgeries. So this is corneal tattooing. So by epithelial debriding as well as by making a corneal pocket, we teach them how to stain the corneal stroma. And this is induction of the corneoscleral perforation. We take a good looking eye and we induce a clear corneoscleral perforation, as well as in advanced training programs, we are going to induce ragged or irregular corneal wounds and the scleral wounds. How to do vitrectomy, how to secure the antechamber, how to secure the limbus, and how to suture the corneal as well as the scleral wounds. This is how we are going to teach them systematically. In addition, for the beginners who want to enjoy the congenital suturing or the congenital dissection, we offer them the congenital or the Pterygium grafting technique. So in addition, the residents who are going to be posted in the National Eye Bank, who are going to assist in eye retrieval of the cornea scleral button retrieval, we demonstrate them how the systematic retrieval is done. So after that, orientation only, they are going to give them few hands-on experience in wet lab. Then they are allowed to accompany the surgeon who is going to retrieve the eyes. In addition, for like people who are going to do keratoplasty, we have different set of triphyans as well as keratoplasty instruments where they are going to look for clear corneas after debriding the epithelium. We are going to define the central portion, and we are going to teach them how to maintain the antechamber so that you can place all the sutures, and the sutures are going to be well trained. So in addition, we are going to teach them how to do the lamellar dissection of the anterior cornea so that we can take out all the anterior corneal tissue layer by layer using the blade as well as scissors. Then we are going to teach them how to suture the anterior corneal graft. So in addition, DMEC is a bit difficult in goat eyes, but we are going to teach them, we routinely teach them how to peel the endothelial structure so that they can get a practical or like theoretical, at least theoretical understanding regarding how the tissues are used. As far as glaucoma is concerned, so I have prepared this module. This is published in Journal of Glaucoma. After doing keratoplasty, we just discard the corneoscleral rim after giving some portion to the culture. But we are going to use this one. On the left side, you can see that the yellow asterisk shows the triphined end of the cornea, and the red asterisk shows the pigmented meshwork, trabecular meshwork, and the blue arrow shows the scleral spur, and the white arrow shows the iris insertion. So beyond that one is our ciliary body, which was there initially. So I take these tissues to the wet lab, and I just hang in front of the slit lamp. You can see here, and I'll try to teach the resident how to do a slit examination as well as diffuse examination, so that they can get an understanding how exactly the angle looks before imagining how the gonioscopy is done. On the left side diagram, you can see that in addition, we can use this corneoscleral rim. You can see that this corneoscleral rim we are visualizing. After that, we are going to define the central portion. So once we are able to define that one, we are going to use a corneoscleral rim which has trabecular meshwork. So we are going to implant this on a clear cornea. This is artificial cornea. You can see the rim is implanted. After that, we are going to transplant this onto a artificial chamber, right? So whatever the air is there in the antechamber, we are going to replace using fluid through an inlet. And this module is now prepared or ready for gonioscopy examination. So this is indirect gonioscopy. You can see after coupling the gonioscopy onto the cornea, you can see we can visualize the angle structures here. So in addition, the residents can also do, or they can also perform MVR assisted goniotomy. This is another example where the mounted apparatus, we are going to transport that onto a slit lamp. In front of a slit lamp, we are going to hold, fix the artificial chamber. Through that one, we are going to teach them indirect gonioscopy also. So this is goniotomy. So in addition, so whatever the newer trends are there, micro-invasive surgeries. So as far as India is concerned, we have only trabecular bypass stent. So in wet lab, we have dummy pieces where we are going to inject them into the trabecular meshwork. We will teach them this is how the stent looks like. This is how it is injected. In addition, we have subcongenital as well as suprachoroidal stents, but we don't have. So, but we are going to use smaller needles, which we are going to introduce through the trabecular meshwork to the respective spaces so that they get a orientation. So in addition, we routinely train, and we have a module for this one also. We score all the senior residents before giving any human eyes, we teach them at least 10 times trabeculectomy on both sides. In addition, releasable sutures on this thing. So this is for just for like practical understanding. Only senior people will do the AGV, but the residents, they are interested. When they are interested, we teach them how to put the AGV, how it functions, how the basic things are done. So in addition, some people who wants to repair the iris tear, who wants to practice the pupilloplasty as well as iridodialysis repair. So using a suture, so how to do a single pass 4 through pupilloplasty or even iridodialysis, we teach them. We simulate them routinely. So as far as vitreoretinal is concerned, there are lesser modules for vitrectomy, but routinely we teach the buckling surgery. Here we are going to take muscles from different eyes and we are going to suture onto one eye. And after simulating 4 recti, we are going to teach them how to put the buckle as well as encerclage, and how to indent, how to see to indirect ophthalmoscopy, how you are getting the indent, how to tie the final knot. This is we are going to teach. So last but not the least, so strabismus surgery, as I'm a strabismus surgeon, there are various models. You can see this is a chicken which is being placed on the thermocol, but this will not give a real situation regarding how the sclera is. So the resident should make a scleral perforation on the goat eye. Then only he's going to learn what how the sclera is, what is the rigidity of the sclera, how he is going to feel once there is a perforation, and how the vitreous looks like when he has made a perforation. So for that one, these are going to be lesser preferred modalities. On the right side, you can see these are silicone modules. Again, you are not going to have any elastic tissue which resembles like a tenon or the sclera. So for this one, I have made this module where you can see on the left side, on the A diagram, you can see the blue asterisk shows the lateral rectus, the green shows the inferior rectus, and the red shows the inferior oblique muscle. So how to identify the inferior oblique muscle, how to disinsert from the insertion, and this is Fink's procedure. So I'm basically going to tell all the theoretical surgical procedures. So what is a 6 mm behind and 6 mm posterior? That's how we were like Fink's procedure, 2 mm lateral and 3 mm posterior, that is Park's procedure, and just lateral to inferior rectus, this D diagram, that is your like Elton Ankin procedure, total anterior positioning, and even the stages of the intranasal transposition. So apart from this, all recti surgeries can also be simulated. On the left side, you can see that is a wire splitting procedure of a recti. On the middle diagram, you can see partial thickness recti are being transposed like it's a partial lamps. On the right side, you can see it's a Farden surgery. On the F diagram, you can see there's a post-equatorial fixation of the globe. So this creates a good memory in front of the residents, so they can learn, and when they are reading the theoretical part, that's going to be very easy. So this is no tenotomy, no dissection, muscle belly transposition, that is Nishida's procedure. So in addition, on the left diagram, you can see that this is superior rectus, the red asterisk and the yellow asterisk shows the supraoblique muscle. So how to hook the supraoblique muscle, how to do tucking. On the right diagram, you can see the most commonly performed surgeries on the supraoblique is posterior tenectomy of the supraoblique. You can see the whole of the supraoblique is being separated, and anterior 2 mm 1/7 of the tendon is separated from the remaining 7/8. So that's how we are going to take a bite from the posterior depressor fibers. So that's how we are going to complete the posterior tenectomy. So on the left side, you can see these are another theoretical hanging lobe tenotomy as well as Harada Ito. So to conclude, in wet lab, a significant number of routine ocular surgeries can be simulated, and to improve the so that we can improve the resident surgical skills. So we often train these in our wet lab. We have these posters. So whatever the resident is interested, we are going to make a group of 4 to 5 people. Then we give them hands-on training. In addition, we have also strabismus surgeries. For all these surgeries, there is a defined ICO score. So whatever score model is there, we have booklets, and we are going to give one sheet for each resident, and we are going to mark them. So once they achieve the required skill, a senior resident or the faculty is going to assess. So once the concerned senior person, says that he has achieved the necessary required skills, and there's a documentation that over a period of time he has improved all of his skills, and he is now able to assist or like do the surgeries on human eye, then only he is allowed to perform the surgery in wet lab. So these are my work pertaining to wet lab training. Thank you.
Thank you, Amar.
Thank you.
And thank you, Singapore Society of Ophthalmology, for doing this symposium. Thank you so much. I would now request Dr. Sunil Garg from American Society for Retinal Surgeons to start the session.
Hi, thank you, Dr. Sharma. It's really a pleasure to be here.
Hi, Sunil. How are you?
Hi, very well. Nice to see you.
Nice to see you. Same here.
So it's my pleasure to be joined by Dr. Sharma.
Sunil, if you permit, I have 2 more meetings to attend. I would like to, start in case it's okay.
Of course.
Is it fine?
Yes, sir. I think that should be okay. We do not have any session after this, so I think we are running 10 minutes late, but then if you overshoot
No,
by
we'll cover up. We'll
10,
cover up.
15 minutes, it doesn't matter. I mean, we don't have really anything after this.
It's nice to see so many people from ASRS, Dr. Sunil, Maria, so many people. And thanks to our Honorary Secretary, Namrata Sharma, who has worked so very hard. Hi, Dr. Varun. Got us together on this virtual platform. So, Sunil, if you permit, I will share my screen.
Perfect.
Okay. Let me let me know if it is visible and audible so that I can start right away. Is it
Yes, I can
visible?
see it from my end.
Okay. Okay. Thanks, AIOS. Thanks, Dr. Namrata Sharma, and thanks all the people from ASRS. I'll be talking on a subject, which is a very commonly performed procedure. And in fact, 1/3 of my vitreoretinal surgeries are diabetic vitrectomies. You see, at the onset, I would just like to have a disclaimer that all membranes in the retina do not require surgery. You see, the reason I'm showing this upper right photograph is this patient, one-eyed patient, was sent because this patient had traction. But as everybody would know, this is predominantly a nasal traction, not involving the macula. The other thing I want to highlight here is that vitreous hemorrhage or the presence of TRD or both do not call for any institution of anti-VEGF blindly, because I see a lot of patients of first attack vitreous hemorrhage, people being injected with anti-VEGF, especially in unlasered retina, because you still have to be prepared for vitreoretinal surgery. The reason I said these two are because a lot of referrals come for these two conditions. You see, this is the same lady who I'm showing. This is one eye, right eye already lost. So you have to be very, very conservative. Conservative means if the patient is maintaining 6/12 vision in a diabetic eye, believe me, there's no rush to hurry. Diabetic, vitrectomy may look simple, but people know that once you are inside, you may sometimes end up with not so desirable sequelae. So we should follow up such patient, intervene only if there is a macular TRD. So this was another patient who had, you see, this is an obvious patient who requires surgery. But what was done to this patient? This patient was given Avastin. And then this patient of PLPR, again a non-eyed patient, you show has rubus iridis, was referred for vitrectomy. So this patient definitely, I would agree, requires vitrectomy. So the indication of vitreous surgery in diabetic have evolved. You see, when we were residents, the main indication was non-resolving vitreous hemorrhage. But now the main indication is a macular TRD or a combined macular or red TRD. And believe me, with improvements of machinery and instrumentation, the threshold of going inside is decreased. Now we no longer wait for a couple of months. It is a vertical follow-up and the visual demand of the patient. So the threshold of MIGS has decreased quite a bit. And the other indication which has been added for diabetic MIGS is a non-responsive macular edema also. So I'll just share a couple of videos here. This is a patient who had bilateral vitreous hemorrhage. This was a relatively simpler looking vitrectomy. And you see the cause of vitreous hemorrhage was this massive NVD here, which was angry looking. So after doing a core vitrectomy, we just truncated this. It is very important to, I normally do it at the slight distance from the optic nerve head, because even if it bleeds, the clot itself can form and I don't need to dislodge. Then, with the same instrument, you clear majority of the vitreous hemorrhage, and even the loose blood, which is there, can be aspirated with the help of this. So this is the loose blood being aspirated. The macula looks pretty good. And at the end of it, you start doing laser. And I still believe laser is the procedure which ultimately, in the long run, for a couple of decades, is going to be the savior. And in case you do not do laser properly and do a half-hearted laser or a laser which is, not occupying all the quadrants, I normally will go parallel to the blood vessel. And the surgery took actually around 7-8 minutes, but the laser took 10-15 minutes. Because I'm very fond of lasering parallel to the blood vessel, not having any escape areas, and do a complete scatter laser photocoagulation as is shown here. Because this patient, if you do not do laser properly, and if you keep injecting anti-VEGFs, you see this is the end of surgery. A very nicely laser retina, And this patient does not require any gas also. We just injected air and came out. This was the end result of this patient. This is one first post-op day. And this was another patient who had a similar result. This is a series of videos from milder to severe diabetic vitrectomy, what all of you also do. So we begin with a core vitrectomy here and you see, I do not believe in the concept of inside out or outside in approach. Basic thing is wherever you find cleavage, because the bug primarily is a posterior vitreous, which is difficult to, to detach. And because there are multiple fibrovascular attachments in a diabetic patient. So what we are doing here is a core vitrectomy, trying to get closer to the retina, trying to identify the hyaloid. Now we have identified the hyaloid, made a hole, and now this loose blood behind the hyaloid will, start coming out from here. You try to take out this, whatever blood comes out. And then once this opening is made in the hyaloid, try to go all around 360 degree so that you can actually truncate the entire cone here. And you find this loose, this firm attachments to the optic nerve area, trim that area. And there may be some ooze as is there. Do not leave behind this ooze for a long time, because this can sometimes, become a difficult proposition at the end of it. So if you allow this blood to accumulate for a long time, this may cause issues later on and become a membrane itself. This is a relatively simpler, attachment on the optic nerve head, which could be peeled. But believe me, all membranes are not easy to peel in these patients. So we did an air fluid exchange after this, after most of the traction was relieved. Macula, although there are exudates, but looks not so bad. So this was the end of this patient's surgery. This was a patient who had diabetic macular edema resistant to 19 injections. And typically we do a core vitrectomy with triamcinolone and forming 2 islands of crystals. You peel off the hyaloid in this patient. And since the lens was not very clear, we called in the cataract surgeon who did a good job to remove this lens. We went in again to complete the vitrectomy. And at this point of time, under air, we injected trypan blue dye to identify the membrane which was causing the traction. This is the epiretinal membrane. And the best instrument which I use is a 25 gauge MVR blade. And after the edge is identified, we go ahead with the Acard forceps and peel this membrane. Since the retina was not looking very good, I injected the third dye, which is the BBG dye, also known as blue ICG, which selectively stains the ILM. And in this particular patient, we peeled off the ILM also. Believe me, not in all patients, we go ahead and peel the ILM. So this was the ILM surgery being done in this patient. And that was the end of the surgery in this patient. So this was another diabetic patient. After doing, separating a lot of membranes, we found in the nasal part, this was a very tough looking, cord-like structure. So you do a traction test, whether it is easily coming without any structural or blood damage to the retina, and use what I call a traction kind of test. And this fortunately came off. Then we trimmed this very hard looking cord-like structure, then diathermized it and truncated till the area it was possible. We didn't trim it till the base. This is the diathermy being used in the same. And this blood, loose blood which was there, was taken out. This was another, diabetic patient wherein we did the vitrectomy. We separated most of the membranes, but there was this, membrane which was on the nasal side. This was the left eye which I was operating. Somehow the manipulation was difficult. So we do a positional kind of vitrectomy. The inferior infratemporal port, which is conventionally the infusion port, I made it upper nasal, then shifted my, stool for the surgery and worked from the temporal side. So what was nasal initially now became inferior for me, relatively easier to manipulate, although you have to do very slow kind of maneuvers because you don't want to cause any iatrogenic issues in this. And this was the nasal membrane, which got ultimately separated from the retina. And then again, as I said, the main job. Then we again came back to the previous ports only, and ultimately ended the surgery with a lot of laser and filled up the eye with gas. So this was another patient, relatively young patient, IDDM patient, had florid kind of retinopathy. You see, this was actually a combined RAG plus fractional RD, and you see the toughness of the membranes. This was the RAG component here. And for a long time could not see the plane. What I did was I created mini PVD, just slightly pulled with the help of forceps. Aim was to separate it from the optic nerve head slightly, so as to find a small plane and insinuate the instrument. So now comes the cutter. Now you can insinuate this between the healthy or the normal retina and this bad membrane here, and then did some segmentation work here. Because there are multiple fibrovascular attachments, aim was to go in between. Then used this separator by Elcon, and then again with this cutter trying to find plane in between the two bullae of the detached retina. It has to be slow, patient. Aim is not to cause breaks. Aim is not to cause bleeding as far as possible. This is, then I injected after they've segmented areas, were there all 360 degrees, injected PFCL just to know where are we now. So this was with the PFCL, you could see segmented. At this stage, after, segmenting some more membranes and, delineating planes, I thought it's better to now switch to bimanual because there are a lot of traction areas on the posterior pole. So with forceps in left hand and, this curved scissor, which is one of my favorite instruments in bimanual surgery, the advantage of this bimanual is the precision. You see, you just lift that area slightly and go underneath it, and this fibrovascular pegs of tissue can be precisely cut. The advantage is that apart from precision, bleeding also is less because you pull less in such. And once you have separated this, then you bring in the cutter again and finally dithermize the remnant stumps. And at the end of it, do airflow exchange, remove this PFCL bubble. In this patient, I had to put in silicone oil. There were, 2-3 areas of retinal tissue where retinotomy was done. And finally, ended up with a lot of laser in this patient. Laser, and laser is the ultimate savior. So bimanual surgery, I feel, is even in the era of 25-27 gauge, is very helpful in especially difficult dissections, primarily because to me, it feels it adds precision and less complications and better hemostasis, and also reduced exchange of instrumentation, reduces surgical time. So this was the end result of this patient, which I have a long follow-up actually. And this, she was initially hesitant because vision was very good. And finally, once we did surgery, this was the end result. This was the result in the other eye of the same patient. This was another patient who had this bimanual surgery done. You see, this is the preoperative picture. This is the postoperative picture. And this is the fundus picture, preoperatively right eye. Another patient, this is the same patient postoperatively. A couple of more patients where this bimanual surgery has really helped me is these are both eyes of the same patient, pre and post-operatively. Fortunately, because disc and macula was good, so therefore the visual result also was good in this particular patient. This was the same patient which I started with the first slide, where patient was referred for rear surgery. This patient we could get 6/18 kind of vision with regression of rubeosis and a lot of laser, as you see. So thus to conclude, diabetic vitrectomy is not a simple procedure. No two diabetic vitrectomy are the same. And normally I would post a diabetic vitrectomy at the one of the last case because it's quite unpredictable. And PVD is generally difficult in a diabetic because of multiple tenacious vascular attachments. And they are tenacious, so they tend to cause break. And since they're vascular, they tend to bleed. So the answer is you should work slowly. Do not pull too much and do more of segmentation and delamination. And believe me, with faster, newer probes, with the port being closer to the tip, the use of scissors also has decreased. But I do, resort to bimanual surgery sometimes. And better machines and better, machine probes and this thing has made the job easier. And if the fibers of frond is angry looking, I do not hesitate to use pre-operative anti-VEGF prior to doing a diabetic procedure. Thank you very much for listening. I'll just stop sharing my screen. And if there are any questions, I will love to answer them.
Thanks, Lal, for a wonderful presentation as always. So for your diabetics, will you don't routinely give an anti-VEGF injection pre-op, just in certain select cases?
No, as I said, if they are angry looking, fronds, I always give. But as I showed the first video, most of them I may not. But it all depends on the look of the retina, if it is visible. If the retina is not visible to me, if it's a massive hemorrhage and I can't assess the retina, then I may not give. I may, go ahead like this. But if it's a pure TRD with multiple, attachments being visible, then and if they are angry looking, then I will.
Lala, I know you have many other obligations and I don't want to hold you up, but we thank you for sharing that expertise and being part of this great symposium.
Thank you so much. Thank you. Really obliged.
Alrighty, next we have a great selection of talks today, focusing mostly about diabetic eye disease. Next up will be Dr. Chirag Javeri. Chirag is very involved in the DRCR network and is one of the principal members of that. And I'm proud to say that he'll be presenting the work on a protocol AC, that's aflibercept monotherapy or bevacizumab first for diabetic macular edema. And he was first author in the New England Journal article that just came out on this topic. Chirag, welcome. Chirag, if you could please unmute your microphone. Thank you.
Thank you. Yep. Thank you for having me. I hope everybody can see the screen. So I'm honored to present. Thank you for inviting me to talk today. And we're proud on behalf of all the other co-authors and all the members of the DRCR Retina Network. I'm going to present to you the results of protocol AC or aflibercept monotherapy or bevacizumab first for diabetic macular edema. These are my financial disclosures. So we know that based on protocol T, patients who received aflibercept compared to ranibizumab and bevacizumab did better in the first year if they had 20/50 vision or worse due to diabetic macular edema. At 2 years, the aflibercept group maintained that superiority compared to bevacizumab. However, the patients who were treated with bevacizumab still did quite well, and therefore we wanted to see if starting with bevacizumab first and then switching to aflibercept would create equivalent results. The reason for this is because, particularly in the United States, we're often required to start with certain medications like bevacizumab due to insurance purposes. Obviously, the reason being is because there's a very significant price difference in the United States, as well as in most other countries, between bevacizumab and aflibercept. However, these decisions that are being put forth by policymakers are done purely for financial reasons, and we did not know if this was potentially harming the patients or if this was a viable strategy. So protocol AC was designed to help answer that. Patients were randomized into either aflibercept monotherapy or bevacizumab first, with the opportunity to switch to aflibercept in certain cases if they met certain switch criteria. The inclusion criteria was very similar to protocol T, and I won't bore over that, but the only exception was that this was looking at only patients with 20/50 vision or worse. Primary outcome was the mean change in vision over 2 years or area under the curve. The follow-up schedule was also very similar to protocol T. However, at 12 weeks, patients had the opportunity in the bevacizumab first group to switch if they met the certain switch criteria. So for the first 3 months, people did not get to switch. Only after 3 months, if they were not responding as well, did they switch. Patients were given monthly injections and then were extended out. And so what was the switch criteria? Well, first, patients had to have persistent edema on OCT and on exam. Patients had to still be given bevacizumab the last 2 visits. So if a patient had done very well and was 20/20 and no edema was there, and they were extended out and then injections were deferred, if they had fluid again, they weren't switched automatically. They were restarted on bevacizumab. So they had to be continually treated with bevacizumab. Also, for the last 2 visits, patients had to have no improvement of 5 letters in the last 2 visits, or no more than improvement of 5 letters, or no more than 10% of improvement of on their CST for the last 2 visits. So not much vision improvement and not much thickness improvement. And then lastly, the patient's vision still had to be compromised. So at 12 to 24 weeks, so within the first 3 months of the opportunity to switch, they had to have 20/50 vision or worse. So in essence, they likely didn't really improve much. They didn't cross that 20/50 threshold. However, after 24 weeks, patients could still be switched if they had 20/32 vision. So these are the patients that maybe they did improve a little bit. They did cross that 20/50 threshold. So initially, they did not meet switching criteria, but maybe they were plateaued off, and our thoughts were, is there an opportunity for these patients to improve a little bit more if we switch them to aflibercept? If they met the switch criteria, they were given at least 2 aflibercept injections, and then after that, they then follow the same retreatment criteria for protocol T, i.e., if they improved and their edema resolved and they were found stable, they would then be extended out and then deferred injections. So the number of participants were relatively equivalent in the 2 groups, and the completion of the 2-year visits were also similar in both groups. The baseline characteristics between the 2 groups were similar as well. The ocular baseline characteristics were similar with respect to vision, OCT thickness, and previous anti-VEGF treatment. So what were the results? So first, the number of injections between the 2 groups varied by about 1.5, with the bevacizumab group needing 1.5 more injections on average over 2 years. If you look, the majority of the injections in the bevacizumab group were bevacizumab, the bevacizumab first group. Almost 7 of the injections out of the 16 were the aflibercept injections. That is, of course, half compared to the aflibercept monotherapy only. How many patients met switch criteria and were switched over? So over 2 years, surprisingly, 70% of patients met switch criteria over the 2 years. More than half of them met that criteria within the first 3 months of them having the opportunity to switch. About 57% who would have switched over the 2 years switched within those first 3 months. So it seems like many of the patients, if they were not going to be responding well to bevacizumab, didn't respond early on. In terms of visual outcome and our primary outcome, which was, of course, area under the curve over 2 years, the 2 groups did not have any difference over 2 years. You can see that the aflibercept monotherapy is a little bit more favorable within the first year, and this is something that we would have actually expected based on looking at protocol T results. Secondary outcomes. Patients who had 20/20 vision or better were similar between the 2 groups, as well as 20/40 vision or better. Very few patients had very poor vision at 2 years in either group. The number of lines that were improved within the 2 groups were also very similar with respect to 3 and 2 line gainers. 2 line and 3 line loss was also very low and also similar between the 2 groups. Patients with respect to CST improvement at 2 years was also no difference. However, once again, you can see that the aflibercept monotherapy group is favored slightly within that first year, but then catches up, the bevacizumab first group catches up in the second year. The number of patients that had complete DME resolution at 2 years was also similar in both groups. So, in terms of adverse events, ocular adverse events were similar with no major difference. In terms of APTC events, also no major difference. However, when we look at other systemic adverse events, there was a statistical difference between hospitalization rates, serious adverse events overall reported, as well as hypertension. However, we do not feel that this is necessarily something indicative of aflibercept monotherapy, partially because many of the other studies that have been well documented, they have not found any major differences between the anti-VEGF, the different anti-VEGFs, as well as it's hard to really say if the bevacizumab first group was specifically bevacizumab related, because 70% of the patients in the bevacizumab first group also received aflibercept. So in summary, 70% of eyes in the bevacizumab group were switched to aflibercept during the 2 years. More than half of these eyes were switched between weeks 12 and 24. There was no overall difference in the mean change in vision over a 2-year period, whether administering aflibercept monotherapy or giving bevacizumab first and switching to aflibercept based on pre-specified criteria. There's no difference in retinal thickness between the groups at 2 years as well. So rescue treatment with aflibercept mitigated the average visual and anatomic differences that we found in protocol T between aflibercept monotherapy and bevacizumab monotherapy. So results from this study, of course, can only be really generalized if you follow the switch criteria and the retreatment criteria. If there's another criteria that's used, it may be this specific result may not be applicable. Having said that, starting with aflibercept, starting with bevacizumab will have significant cost reduction impacts compared to just starting with aflibercept in patients who have 20/50 vision or worse. So in this trial, no significant difference was found, and initiating therapy with bevacizumab is a reasonable and safe and effective alternative to aflibercept monotherapy. Thank you, and if you have any questions, please, I'm happy to answer them.
Thanks, Drag, for a great talk. I know this has generated a lot of active discussion here in the US in terms of what to do, because I think based on protocol T, as you alluded to, a lot of us have started switching, especially our patients with moderate vision loss or severe vision loss, starting with aflibercept, just because the initial results were so great. So from a practical perspective, how do you sort of integrate those two? Have you switched now to saying, well, even if somebody comes in with 2100, I'm going to start with bevacizumab just because it seems to make sense based off of the AC results? Or will you say, you know what, it looks like you have bad edema, aflibercept is a stronger drug, there's a reasonable chance you're going to get on it anyway, why not just start maybe a bit more aggressively off the bat?
So that's a great question, Sunir. And the thing is that this was meant for us to be able to have allow all of our different treatment patterns and see how if all of them are justified, or not all of them, but many of them are justified. You're right. You can argue both ways. And this is not meant to be a study that says you should only do it this way. It's also not meant to be a study that's meant to support step therapy as a general guideline or policy, right? If anything, this is meant to say we should be looking at studies before we have policies that say everybody needs to be starting on this medication or not. Having said that, we're also looking at, and we're going to be actually coming out with a secondary manuscript regarding some of the risk factors to see if there's anything that we can tease out on even the patients who switched and what type of risk factors are, similar to what was done with Protocol V and how baseline thickness and severity of diabetic retinopathy led to the likelihood that patients were going to need to be treated in patients in Protocol V. Having said that, I do try to start off with bevacizumab if I can in most patients. If they have a lot of edema, I may tell them and say, hey, look, this is the result. You're most likely going to need to have aflibercept anyways, so we may want to start off. But I think the biggest thing it makes me feel more comfortable is that because we are sometimes forced to start with bevacizumab, I can tell my patients that, hey, or I feel more comfortable that I'm not necessarily, or we're not necessarily starting off with an inferior strategy, as long as we have that opportunity to switch to aflibercept in the setting of no response. And that's something that we have to be active about. That's something that we also have to fight against the insurance companies to make sure that they're aware of that and don't change their policies and say only bevacizumab, for example.
Terrific. Thank you very much, Chirag. That was a great presentation. And then building on that, I'll next introduce Dr. Varun Chaudhary. Varun Chaudhary is professor of ophthalmology at McMaster University in Hamilton, Ontario, and is really on the forefront of doing new network meta-analysis for a lot of our clinical trials. And he'll be sharing a little bit about that with his talk on management of center-involving diabetic macular edema, the need for a pragmatic treatment paradigm.
Thank you very much, Sunir, and the planning committee for the invitation. Can you see this screen, Sunir? We good?
Yep.
Perfect. Thank you. So wonderful. Yeah. So for the next few minutes, great to follow up with Chirag's New England Journal paper. Mine is clearly not that impactful, but hopefully there'll be some interesting points and discussions people can take away from this. Topic is what we talked about a minute ago, center-involving DME. Clearly a very important question for us as ophthalmologists and as clinicians managing these patients. Here are my disclosures. So what's the clinical problem in practice? We know clearly anti-VEGF agents are first line of treatment for center-involving DME. This is built on robust explanatory trial evidence. But we know DME is a chronic disease. We just heard about treatments over 2 years, a lot of treatments over 2 years. So it's not just about what you start a patient with, it's how you manage them moving forward. And as clinicians, there's really two paradigms we can look at. We can look at a continuous treatment paradigm where you can either use treat and extend or fixed dosing, where you have a constant suppression of VEGF, versus a discontinuous treatment paradigm such as PRN treatments. Now, in clinical practice, I'm sure all of us have a go-to paradigm that we like using for most patients. But from a patient perspective, the question becomes, are we confident that the paradigm we're using in clinical practice, in fact, are equivalent and give us similar results? So to explore that question, I thought I'll break it down into 4 key concepts we can touch on briefly. First being, let's look at some of the key challenges in DME management and see what paradigms need to address to help move the field forward. Secondly, look at actually how different treatment paradigms compare with each other in terms of some of these key outcome parameters. Thirdly, let's look at where are some key evidence gaps in the field. And lastly, how can we move the field forward? So key clinical challenges in DME management. I think we all see this every single day in our own practices. Number one, high treatment burden, high monitoring burden. We have long-term results from Protocol I, DRCR-NET study, 5-year results, ranibizumab with early prompt versus deferred laser for DME. Very impressive results. Great, robust vision gains early on, which were maintained out to year 5. So it looks like a discontinuous PRN treatment algorithm works very well. But important to remember that despite the paradigm itself, there was ongoing need for anti-VEGF treatment. Yes, it reduced significantly after year 1, but even years 4 and 5, over or close to 50% of patients needed ongoing treatments. Even more importantly to remember, to get the results they got in Protocol I, the monitoring burden was very high. Not just in year 1 and 2, but even years 4 and 5, patients needed to be seen 4 to 6 times a year to ensure you could catch them early and retreat them early using a discontinuous treatment paradigm. And lastly, as the DRCR-NET acknowledges, it might be difficult to replicate some of these paradigms, which are not easy to replicate in clinical practice. They're not very pragmatic, some of these. They have come up with interesting and important modifications to them. But the question becomes, are these modified paradigms equally good as what we saw in Protocol I? And that question remains unanswered. The second challenge in DME management is heterogeneity in terms of response. We know early on patients need a lot of treatment, but we have extension study results. These are extension studies from RISE and RIDE, that 75% of patients will need ongoing treatment. Some need less, some need a lot of injections, and we don't have a mechanism to predict who will need less or more. This is using aflibercept extension study of the VISTA trial. Very similar results. 75% of patients in the extension study needed ongoing treatment. 25% needed 11 or more injections. So clearly a lot of heterogeneity in response, and there's no way for us to predict who's going to need less or more. The third challenge is maintaining long-term visual outcomes. Explanatory trials that get drugs approved are usually 1 or potentially 2-year outcomes. What happens in the long term? We have long-term data from protocol I and protocol T. Important to remember selection bias. These are patients who were motivated patients who were obviously in clinical trials. They were able to keep up with very high monitoring burden. Protocol T had 14 visits between years 3 and 5. Protocol I had 20 visits. There was a median of 4 injections required in both studies. And what happens to visual acuity in the long term when we use a discontinuous treatment paradigm? Yes, we got 2.5 lines gain of vision from baseline to year 2 when patients were in protocol T and treated as per clinical trial algorithm. But when that was applied in a real world setting from years 2 to years 5, patients lost a line of vision. And that was despite the fact that the OCT thickness was only 1 micron difference between years 2 and 5. So something's happening. It's not simply that the macular edema is not being controlled. That was very well controlled, but patients lost vision. So long-term data suggests patients, 75% or so, will need ongoing treatments, 3 to 5 injections annually, and there is a tendency to have gradual vision loss. That's visual acuity. Let's also look at anatomic outcomes. We know anti-VEGF agents are very good at causing regression of diabetic retinopathy severity score. About 30 to 40% of patients can have a 2-step or more reduction in diabetic retinopathy severity. Why is that important? Because DRSS has been correlated with health-related quality outcomes for patients. And as DRSS score gets worse, patients' quality of life decreases. But what happens when we use a long-term discontinuous treatment paradigm? Endurance and open-label extension studies looked at this. We lose the advantage we gain early on in terms of regression. Diabetic retinopathy severity scores get worse when we use a discontinuous treatment paradigm in the long run. So given some of those challenges, then the question becomes, what we use in clinical practice? How well does it actually work? What's the evidence that they're similar or equivalent in terms of outcomes? So we need to remember in medicine, there's the hierarchy of evidence, and on top of the pyramid, even above RCTs, is meta-analysis of RCTs. So my colleagues and I decided to look at this question and carried out a meta-analysis looking at treat and extend versus alternative anti-VEGF treatment dosing for center-involving DME. This was the research questions. We included studies where patients had center-involving DME. The intervention arm received anti-VEGF using treat and extend. Control arm received anti-VEGF using either PRN or fixed dosing, and a primary outcome was visual acuity at year 1. We followed the Cochrane guidelines, pre-registered a protocol with Prospero, identified 22 unique studies with 8 RCTs. So what did the results show? So this is why this is looking at visual acuity results, treat and extend versus fixed dosing. Conceptually the gold standard in terms of DME management. Vision at month 12. So just to orient everyone, this is the line, vertical line is a line of no difference. We have individual studies listed here, and this is why meta-analysis is a powerful tool. When we look at one trial, TREX DME, for example, you have a point estimate and 95% confidence intervals. Because of random error, we don't have good precision. But when we pool the data at the bottom, we get that pooled estimate, a very tight diamond with small confidence intervals that crosses line of no difference, showing treat and extend is similar to fixed dosing in terms of visual acuity. What about treat and extend versus PRN dosing? Once again, the pool estimate crosses line of no difference. It appears they work equally well. When we looked at CST, CRT outcomes, similarly, pooled estimate shows no difference. What about treatment burden? Well, treat and extend versus fixed dosing, there was no difference, but again, very wide confidence intervals. Treat and extend versus PRN at the bottom, there appears to be a benefit for PRN with fewer treatments. But if you look at the number of patients in this pooled analysis, was 19 one arm and 66 in another. So only 150 patients were we able to pool the data to come up with this outcome. But nonetheless, it appears that all treatment algorithms are giving you similar results. So can clinicians rest assured that no matter what you decide to do in practice, you're optimizing, you have the potential to optimize outcome for our patients. Now, one key part when you look at a meta-analysis is to go a step further and look at certainty of evidence. And we did this using the GRADE approach, a well-established methodology to look at certainty of evidence. And when we looked at that at an outcome by outcome level, what we see on the right is that certainty of evidence is actually very low to low for many important outcomes. That tells us that we need to generate more evidence because we simply cannot be certain that the data I present actually holds true. Also, the meta-analysis identified important gaps in the literature. All treat and extend trials thus far have used different treatment algorithm. None of them checked whether what was prescribed in the protocol was what clinicians did. So how reproducible are these? Majority of them extended patients out to 12 weeks. Can we go longer? And most of them did not look at important biomarkers such as retinal non-perfusion. Do treatment algorithms have different impact on key biomarkers? So how can we collectively move the field forward? So I'm happy to announce that in the next couple of months, we'll finally be ready to launch this INSIGHT DME trial. I'd like to thank my co-investigators who've been working on this with me for the last couple of years. This will be a pragmatic multinational RCT. The primary objective here will be to determine if a 4-week pragmatic treat and extend regimen up to Q24 weeks with faricimab versus fixed dosing at Q8 weeks with faricimab produces non-inferior visual acuity outcomes from baseline to week 100. The primary outcome will be mean change in BCVA with a tight non-inferiority margin of 3.9 letters. We'll look at a number of secondary outcomes: diabetic retinopathy severity score, fluid compartments, retinal non-perfusion, and of course, visual patient quality of life and safety outcomes. Some key methodology strengths, I think, of the study: large number of patients. So hopefully we'll get a precise estimate and small confidence intervals. We'll be recruiting patients over 4 countries, so hopefully the results are generalizable. And we'll be using a reading center at McMaster to ensure high internal validity, because we'll be checking that clinicians are actually able to reproduce the algorithm we are proposing. We hope to launch this in Q2 of this year. So with that, thank you for your attention. And thanks again, Sunir and Maria, for the invitation.
Thanks, Varun, for a really great talk. Chirag, if I can get you back on as well. So, Varun, I think you very nicely highlighted the fact that there's certain questions that we just don't know the answers to. And for some of them, if these large data sets don't already provide it, how do we go about prioritizing which questions we're going to answer when we're looking at precious resources in terms of money and physician time, and we know that there's gaps, but some gaps we just may never have answers to. So how do we work through those issues? Brian, I'll turn it over to you first, and Chirag, I'd love to hear your thoughts on that as well.
Thanks. I mean, at a very fundamental level, I think the way I think of these questions is we get explanatory trials that are very good at telling us a drug or an agent device working under ideal conditions, and they get the drugs and agents approved. We have noticed in retina, at least for 15 years, this major efficacy gap that what we see in clinical trials, we simply cannot replicate, and our patients are not getting the benefit, are actually performing a lot worse than we are in real world practice. So in terms of questions, I think the way I see this is, how do we bring those clinical trials, close that efficacy gap? And how do we do that? I think by having simple, pragmatic ways, trials that show us how to optimize outcomes with different agents that we can actually replicate in real world. And I think as long, my bigger goal would be using pragmatic RCTs to try to lower the efficacy gap. So that's how I like to think about some of the questions we can explore.
Yeah, I think, Varun, you said it very well. I mean, I think one of the other ways I think about this is, I think, as you alluded to, the clinical trials are these ideal patients, or hopefully ideal patients, that have relatively good compliance, even though actually the diabetic studies often have some of the poorest compliance compared to other disease processes. But I look at that as that ideal. That's where we start off with understanding and knowing that the results that these studies have with respect to the efficacy of the drugs, as well as the visual outcomes, are probably not going to be achievable in every single patient in that walks into your clinic. But knowing where the trends are, knowing what likely will be helpful, allows us to then make those decisions on an individual basis. And like, as you alluded to, maybe In some patients, we will treat more aggressively initially based on their thickness, maybe based on their personality. Maybe compliance may have an issue where you may be more likely to go to surgery sooner because you're not sure that they're going to be coming back just for injections or whatnot. So that's the way I look at it, is that these arm me with the direction I need to head, but you cannot be with blinders and saying, I'm just going to follow the protocol. That just can't work. And so you have to you have to treat the patient that's in your chair, not just follow the protocols.
Terrific. Thank you, guys. I really appreciate that insight and great talks. It's my pleasure to introduce Dr. Maria Barakal. For those of you who have not met Maria, Maria is one of the most sought after speakers in our profession. She's given over, I think, 600 lectures around the world. She was kind enough to come to Wills recently. She's won multiple awards, including the Founders Awards from ASRS, and she's one of the most talented surgeons I've ever seen, and she'll be sharing some of her insights into minimal membranectomies on the management of diabetic TRDs. Welcome, Maria.
Thank you so much, Sunir. It is a pleasure for me to be here. I'm going to talk to you about this technique that I came up with. Are you seeing my screen? Okay. Okay, so traction retinal detachments really affect many of the diabetic patients. 40% of all vitrectomies in diabetic eyes are for TRDs. And traction and rhegmatogenous detachments account for 20% of all vitrectomies. We know that tractional retinal detachments are more common and severe in younger diabetics, and it's because a vitreous detachment is protective. It is protective not only for progression of retinopathy, but it is really the mechanism by which traction retinal detachments occur. So most of the people that are affected by this tend to be younger, unfortunately. We all know that the goals of vitrectomy for a traction retinal detachment is to remove media opacities and remove anterior, posterior, and tangential traction. But despite all the advancements that we've had in vitrectomy, we still know that a large proportion of eyes experience visual loss with vitrectomy and anatomic failure. And iatrogenic breaks occur in between 29 and 37% of all eyes that undergo vitrectomy for traction retinal detachment. And that gives you very poor prognosis. In monocular patients, it's even more challenging. I'm often, I see a monocular patient, his only eye has a traction retinal detachment. I know it's going to get worse. The patient had a bad response in the other eye, and those eyes do badly. We know that 52% of eyes that have a blind fellow eye will have decreased vision with vitrectomy, and 13% will end up NLP. And when we looked at the fellow eye study, once an eye requires surgery, 38% will require surgery in the other eye within 1.6 years. And Latinos, we know that Hispanics actually have a higher incidence and more severe diabetic retinopathy, higher incidence of diabetes. I practice in Puerto Rico, and they have 3 times more visual impairment in the US than non-Hispanics. And vitrectomy for TRD from the LALA studies, 40% had worse visual acuity post-op than pre-op. And the mean post-op vitrectomy visual acuity was hand motions. So, we know that these eyes do poorly. So how did I come up with this? Well, this is a patient of mine. I had done the other eye. The other eye had a very similar traction detachment with very massive fibrous tissue. He was a 60-year-old heavy smoker. I operated the eye twice. It ended up NLP. And the second eye looked very similar. It's this eye here. And I had been following him for 11 years, and the vision kept getting worse from 2070 to 2400 because of this fibrous tissue that kept forming. From the OCT, I knew that the fovea was attached in the center, even though it looked, fairly ischemic. But I kept avoiding. He wanted surgery, and I said, well, let's see you in 3 months. because I really didn't want to go into this eye because I knew, what had happened to the other eye. So I thought about what I could do. So I said, maybe this is the eye, maybe I can just clear the center because I knew the vision had gotten much worse because of this fibrous tissue. I couldn't really open this except with diathermy. I tried with everything. It was very taut. So I made an opening with diathermy and then I opened all around. And I said, I'm just going to open the center and do some relaxing incisions in that thick membrane that had centripetal traction, and then clear all of the attachments from the vitreous to the periphery. And this is the eye. And he maintained 20/70 vision just by doing this for 5 years until he died. So after I did this, when I did the surgery, I was very careful not to create any traction, not to create any breaks. And I have been doing this on a number of patients that have similar situations. And I published this and I thought about, how to reduce the risk. I did it initially on one eye patients, but now I do it on very severe eyes that look sort of similar. And included 9 eyes, 7 were male, 2 female. The average age was 58. Duration of retinopathy of diabetes, 24 years. And I followed them for a mean of 4.5 years. And basically the surgical technique is I did them in 27 and 25. 4 of the eyes had combined phaco-IOL because there was significant lens opacities. And basically I used high-speed cutters. I removed all of the attachments of the vitreous to these membranes wherever they were. And then I opened the very thick hyaloid. And not only did I free the center, but I did these radial incisions, which are really, really important because you don't want that centripetal traction to continue progressing. And I did not leave tamponade. I added laser in areas of attached retina where it was necessary. And I'll show you more cases. The OCT is really important because this eye may not look that bad, but obviously it had, the macula was detached. The visual acuity was 2100 and the post-op picture is on the right, it's 2030. This is another eye, which 45-year-old. At 2200, I could see by the OCT that the macula was detached, macula was attached afterwards, and the center was free. And here you can see the surgery, and they all have in common, this very, thick fibrous tissue just going through everything, basically a very thickened hyaloid. So this one, I was able to open it just with the cutter instead of having to use the diathermy like in the first one. And then I'm just opening it all around. And you can see as we do this, how much traction is there, particularly when we do the relaxing incisions here, because you see how the tissue all pulls back towards each other. I just do relaxing wherever I feel it's completely safe to do that. So because I really don't want to create an iatrogenic break, this was, the best eye of this patient who was a musician, and he has maintained really good vision for a long time. This is another eye, monocular visual acuity 2400. From the OCT, I could see there were traction areas. I'm doing it 27. And again, the same thing. I'm just removing all the hyaloid in the periphery, all of the attachments throughout. Then sometimes I start, from the inside out. This was a more complex patient because it was not only the very taut, thick hyaloid, it also had some membranes. So I'm just clearing all that, doing the relaxing incisions. I do not have intraoperative OCT, which would have been nice in this case, but I'm just going around freeing, wherever I see that there is no means of me doing breaks. So I'm just doing those relaxings around, and there's still membranes there. So I'm doing this with the 27 gauge vitrector, which I think is very useful for this because it really controls aspiration in. I'm using forceps here just to clear that membrane that was still there. I'm just changing some of the light filters to try and see it better. And I'm doing this, very carefully because I certainly didn't want to create a break. You can see the subretinal membranes there because this was very long standing. area. You know, the posterior pole had been tractionally detached for some time. So I'm just clearing all that, getting under the membrane, doing like blunt dissection from side to side, trying not to cause any traction there, because that, you know, as you can see, it was tractionally detached. You can see the retina moving. I make sure there's no attachments left towards the periphery. And in this case, I did leave air, and I applied more laser to the periphery because I wanted it to try and position him for 1 or 2 days to try and flatten the fovea. See how nicely the fovea flattened, and it maintained 20/70 for a long time. So our results were pretty good. You know, all of the patients improved vision, at least 2 lines, and had an attached macula. Complications were vitreous hemorrhage, and I always do in-office fluid air exchanges. I think it's a really useful technique. I have a video on it in I2, and it really keeps the patient from having to go to the OR again. And as 2 patients had posterior capsular opacities treated with YAG. So I think that doing this technique in really high-risk eyes is something that will keep you from losing eyes that in the past I used to lose by trying to be too aggressive and remove all of the membranes. We really don't need to do that. We have to think about what we want to accomplish in each case. I think the OCT is priceless for that, to really know the status of the fovea. And you know, most of the patient's vision really is the fovea. So in summary, this minimal membranectomy to relieve traction should be considered in high-risk eyes. And the key to is it remove all of the vitreous attachments to the membranes and do radial incisions in the membrane to relieve circumferential traction. So thank you so much for having me here. It is an honor to participate. So thank you, Sunil.
Thank you, Maria, for a great talk. You know what? I think a lot of us are used to seeing these videos at conferences where all the fibrovascular tissue is gone. So I think there's a sense that, you know, should be our endpoint. But I think your point of, you know, what are your surgical goals? And your goals aren't necessarily to make the retina pretty as it is to preserve vision and to sort of disable the TRD is an important one.
I agree. We always, you know, I'm always telling myself in every surgery, enough, you have done enough, because oftentimes, and I err from this, I want to have it better. Oh, maybe I should try and remove this nasal membrane, which really is not causing any trouble. And then I get a break. And then, you know, you really are committed to removing everything, putting maybe gas in, long-acting gas, and that's when things go downhill. So it is a lesson in humility that perfection is the enemy.
Are there any specific strategies, you know, for the most, on the last case you showed, that was fairly avascular with, I think, different surgical planes. Any techniques that you use when a patient comes in with a very sort of active, you know, very vascular disease and they haven't had much PRP before, and you know, there's some concerns when you have that circumferential traction that if you are too aggressive with anti-VEGF, you may pop off the fovea. How do you approach those eyes?
Well, if an eye has not had PRP, I always do PRP before. And I make sure not to put it very close to areas where membranes are, because I don't want any contraction. PRP can cause contraction too, not only, you know, anti-VEGF. And if it's many of these eyes, I do not put anti-VEGF before because I'm really afraid of contraction unless it's super vascular and I know that it's going to bleed a lot. But nowadays, you know, when we do small gauge and we have valve cannulas and we can really control the pressure, we can really control intraoperative bleeding way better than we did, you know, in the past. So that's not such a big, you know, concern. I don't routinely inject anti-VEGF on all the cases. These cases don't need anti-VEGF, you know, they're not really vascular. So I just do it from case to case.
Terrific. Thank you very much, Maria. We always learn so much from you. Next, this will be our third and final talk on diabetic TRDs. It's a pleasure to introduce Dr. David Chu. Dr. David Chu is working with us at Wills Eye Hospital. He was one of our fellows, and he's a superb surgeon. He's also very committed to education. He has a website called iGuru, which I guess is appropriate for the Indian Ophthalmology Society. So iguru.org has a bunch of different videos and lecture series on different talks in retina and other ophthalmologic conditions as well. David, welcome, and we look forward to hearing from you.
Well, thank you, Sunir. Thanks for the invitation. And thank you to all the other speakers who've come before me and who will come, and thanks to the audience as well. It's a pleasure to be here at the International Ophthalmic Conclave. So first thing I'll say is hang in there, everyone. We're going to slam you with more videos. Hopefully it's the last one. Try not to get bored. And I wanted to share with you some thoughts about diabetic TRD. Dr. Garg taught me. I graduated from a fellowship, what was it? Oh, I think in 2020. And I'd like to reflect on what he has taught me, what other mentors have taught me, what I've learned over the last couple of years in independent practice about this very challenging unmet need in our field. Let me see if I can advance this slide here. No relevant disclosures. Bausch & Lomb makes vitrectomy instrumentation, but what I'll talk about with small gauge vitrectomy is applicable to all platforms here. It was the advent of vitrectomy in general to treat diabetic vitreous complications. And here, half a century later, in 2023, diabetic TRD is still one of the greatest unmet needs. We've improved a lot in our visualization, small gauge instrumentation, anti-VEGF. It's made our surgery more safe and more efficient. But nonetheless, the basic tenets of doing diabetic TRD, as Dr. Barakal said, as Dr. Verma said, is to completely remove the hyaloid, so I'll echo that, and the associated fibrosis along the posterior part of the hyaloid. It's a misnomer to say it's pre-retinal fibrosis, although I will continue to say that, but it's really fibrosis grown along the hyaloid. Separation of that and attacking areas to preferentially remove that fibrosis and that hyaloid from the retina is the goal of diabetic vitreous surgery. And along with that, allowing the retina then to settle down to remove the traction from tractional retinal detachment, and along the way, do as much as possible to avoid iatrogenic retinal breaks, because the presence of retinal breaks and residual traction will require potentially a long-term tamponade like long-term gas or oil, and increase the risk of complications like recurrent retinal detachment. So on that note, I'd like to present what I think of as a typical, prototypical advanced diabetic case over here. I hope the video plays well, but this is a patient with encircling fibrosis, and importantly, who has detachment, complete macular detachment, as well as detachment extending deep into the mid-periphery, 360 degrees, with very limited opportunity for PRP. And this goes back to that age-old concept in surgery of sharp versus blunt dissection. Here in the retina, we talk about delamination and segmentation. It's always been said from many people and from long ago that you should never completely try to tackle these dense membranes with delamination alone, to try to peel them with forceps because of the risk for iatrogenic retinal breaks. So what I'd like to start off with and propose to everyone is to use that forceps not to completely remove those membranes as a whole, but really to pluck at them, to reflect those edges, to tease at them, to move that fibrosis and the retina along with it. That will dynamically allow you to assess where these membranes are attached, find the weak areas, and then use small gauge cutters like 25 or ideally 27 gauge instrumentation to get rid of those fibrosis, those areas of fibrosis with segmentation. That, I think, gives you a lot of efficiency, gives you a lot of intel about these membranes, and allows you to proceed more efficiently. So don't forget about the forceps, even as you see so much being talked about with the cutter and the segmentation. So that's the first thing I'll talk about. The second thing, stretched retinal holes are not uncommonly associated with tractional retinal detachment, leading to a combined regmatogenous and tractional detachment. They're often located underneath these membranes. They may not be known about until you get to the operating room. So here's another prototypic case, a patient with confirmed TRD on V-scan, but overlying dense vitreous hemorrhage, precluding good view to the retina unless that's clear. So as we clear the vitreous hemorrhage, as we continue to clear that fibrosis, and then we remove some of the pre-retinal liquid blood over the surface of the retina with a soft tip, we then find ourselves engaging an area of subretinal fluid and chronic dehemoglobinized subretinal hemorrhage in Schlerin. So you can see that hole, it's got rounded edges. You can note that it's chronic. So what do you do with this extramacular hole? Here I propose a use of ILM peeling, which is something I do for these extramacular holes, but also for macular holes and also for other indications in diabetic surgery too. And so I'd like to extend that peel all the way out to the area where that hole is. It allows for relaxation of the tangential traction. It gives slack back to the retina. This is the same concept that we use when we treat just regular old full thickness macular holes. It's helpful in this kind of situation as well because it prevents surface proliferation coming out of that hole. Often you will see that, as you could see some pre-retinal proliferation, true pre-retinal proliferation like PVR. That is different than the normal proliferation along the posterior hyaloid. That is typical of just a tractional diabetic disease. It's also very helpful for island peeling when you remove, when you fail to remove or you feel it's unsafe to remove residual fibrous membranes to further relax the macula. And that goes back to what Maria said, to help just allow that macula to settle back. The next thing I'd like to talk about, the peripheral cortical vitreous. So when you think about encircling TRDs, everyone says, well, we got to relieve the traction from this encircling fibrosis along the arcades to the macula. It's also important to think about what happens beyond those arcades. And you got to segment that traction from the arcades to the ora serrata as well. And so those areas are equally important to address. Here's a case highlighting that. This case is not a complex diabetic TRD here. The dehemoglobinized vitreous hemorrhage, the tractional fibrosis over the macula is quite easily segmented. It's very easy and attractive and tempting to say, you know what, I've gotten rid of those membranes, I freed the macula, I'm going to go home. But this is not a terribly complex case. It's not high risk, is what Maria was saying. I like to use triamcinolone in almost every diabetic case at the end of dissection of the visible membranes. It helps to highlight the residual cortical gel. You can see in this case, there's a lot of cortical gel that was attached in the periphery. Segmenting that is really important because it reduces the incidence of persistent traction, not in the macula, but from the outside edge. That can lead to recurrent vitreous hemorrhage or even the formation of new retinal breaks leading to a recurrent detachment. Related to that is something else that triamcinolone can help identify, and that's vitreoschisis membranes. It goes by many names. It's completely separate from the posterior hyaloid. This is something that's present in the periphery as well as in the macula, and it's overlying the pre-retinal surface. Is very common in diabetics, especially these young diabetics. Getting rid of this can also help avoid contracture as well as hemorrhage. So here's a moderately severe diabetic patient here. You can see that while the retina is attached, there's complete fibrosis encircling and growing over the macula. We use our techniques using the forceps to identify where those weak areas are. We segment that with the cutter, and then we finish off with some triamcinolone. And what you'll see here, even after complete removal of those membranes in the hyaloid, is this thin sheet, nicely highlighted by the triamcinolone. This is the vitreoschisis membrane. Getting rid of this can be very helpful, and it's very common to see this in diabetics. We're using the cutter here to aspirate and remove these membranes, but you can also use a flex loop or another scraping instrument like a Tano scraper. I think it's been highlighted by Dr. Barrico, by Dr. Verma, that treatment preoperatively with PRP can be very helpful. I definitely agree. One of the advantages of doing PRP over anti-VEGF is that you can do this in advance of surgery by a great deal. You know, most of the times people agree that anti-VEGF preoperatively can be helpful, and most people would do that days or maybe a few weeks beforehand, but you can do PRP months or well in advance of the need for TRD surgery. This may help induce more gentle contracture of the fibrosis, allowing for more room, that separation from the posterior hyaloid and fibrosis and the surface of the retina. And again, it helps quiesce neovascularization same way that anti-VEGF works. And importantly, it provides that retinal countertraction. And going back to the idea of the advanced TRD, one of the things I think that is really challenging for us and can be very challenging to win for surgically is when you have a near pan-retinal detachment, where the macula is detached, where the periphery is detached, where you have limited opportunity for PRP, and you have to find and take that dissection out into the mid-periphery. That's where you're at the limit of visualization. You're at a point where the retina is thin. You're at a point where the retina is very mobile and where the fibrosis may be broadly attached. Those are situations that are very risky and challenging for diabetic TRDs. So I'd like to show a case over here where complete PRP was applied preoperatively. You can see that this has really greatly helped the surgery because the vitreous hemorrhage is dehemoglobinized and the membranes have separated from the surface of the retina, this great room. And it's really reduced this case to a very simple case where you're just segmenting these light membranes, and that'll be the end. That's greatly helped this patient. Here's another patient here who's a 40-year-old type 1 diabetic, dense vitreous hemorrhage, presenting new for us. And you never know what you're going to find underneath these membranes, especially in a patient who has recurrent bouts of vitreous hemorrhage. But we're happy to find the patient actually had very dense and aggressive PRP. By some standards, some people would say, you know, that's very dense and aggressive, more than it's necessary. What you also note in this type 1 diabetic is almost complete absence of any tractional detachment at all. And that's one of the benefits of doing PRP. Type 1 diabetics, I do think, benefit a lot from PRP because they have a lifelong battle with this kind of thing. And sooner or later, vitreous hemorrhage may rear its head, even if they're well into their 40s or later. I'll give you one more example. This is something sort of uncommon. Here's a type 1 diabetic in their 30s. And there's dense dehemoglobinized vitreous hemorrhage, and there's a retinal detachment here as well. And so we take this patient to the operating room. You notice that there's shallow macular detachment. There's mostly complete hyaloid separation, especially in the periphery. So we're lucky. And we're very happy about that. There's no PRP, there's no opportunity for PRP. You can see that the detachment is extending into the periphery. One thing that you'll note, curiously, in this patient is that there's not a lot of TRD over here, although there is a lot of detachment. And you know what? Young people in their 30s can get retinal detachments, can't they? You can note here in the inferior nasal periphery, there's an atrophic hole. This is pre-existing. This is the source of this patient's detachment. I've seen this a couple of times, 3 or 4 times over the last 2 years. A scant amount of traction, vitreous hemorrhage being present, panretinal or near panretinal detachment with an open retinal break in the periphery. Patients who have atrophic holes are not uncommon. Patients who have atrophic holes and some degree of traction due to diabetes, that greatly potentiates the possibility for leading to a frank retinal detachment, as has occurred in this case. That's the causative break. It changes the game. This is a patient not with a tractional retinal detachment from diabetes, but a regmatogenous detachment complicated by the fact that they have type 1 diabetes and some degree of traction. So what do you do over here? Well, you can't just do vitrectomy on a 31-year-old who has an atrophic hole-related retinal detachment. That would not be the most ideal thing. We've peeled ILM, we've removed some cortical vitreous schisis, and what we're going to do after even we started vitrectomy is we'll add a scleral buckle. We got to address the vitreous hemorrhage, but we got to treat this eye like a retinal detachment associated with lattice degeneration and atrophic holes. We're going to apply PRP, we're going to treat the break, we're going to flatten the retina, and we're going to leave gas for this patient's eye. I'm not saying that every single time you got to add a scleral buckle, but certainly if the patient in the eye calls for it, there's already some intrinsic contraction, not just contracture along the hyaloid, as is a typical diabetic, but here in a regmatogenous case, you're going to have some contracture intrinsically of the retina. That may be something to consider as well. And so that's the end of my talk. Thank you for your attention.
Thank you, David. Those were really cool cases. Is there like a standard approach that you take for your diabetics? Do you use a certain gauge routinely? Do you put your ports in a certain place? Or do you sort of vary those things depending on what you anticipate finding intraoperatively?
Yeah, I mean, I think that I do to a limited extent. I almost always, if it seems like I'm going to need to be doing some significant dissection, I start off with unimanual 25, hybrid 25 and 27 gauge vitrectomy. And I'll do as much as I can with that 27 gauge. I'll have a forceps on hand at the start of the case so I can just do that interrogation of the retina. And then as far as needing to do special things, most times I feel like the membranes are amenable, but sometimes you really do have to turn to bimanual surgery with illumination from a chandelier and get out the scissors or get out other instruments to help you. Sometimes you have to use a lighted pick. That situation is really very special and unique, and I don't generally recommend that because sharp dissection really works better. And a lighted pick typically is a delaminating tool for removing the hyaloid from the detached peripheral retina. There's a lot of unique circumstances. Changing the orientation for which you attack the retina, sitting temporally, is something that you may have to consider doing too. Sometimes you have to plan for it. Sometimes you can actually add more ports to the eye. It's not a big deal to do that, really. And you can really, when you really start to need to fight, you can definitely do all those kinds of things. Absolutely.
Maria, if you're still available, so do you routinely use 27 gauge cutters for segmentation and delamination, or do you think our newer 25 gauge cutters with a bevel tip are sufficient to do pretty much all of our cases nowadays?
For the very bad diabetics, I really like the 27 because it being smaller, it can access very tight tissue planes, which sometimes the 25 is too big. But the 25 works really well too, but I just think I get more finesse in being able to shave on the surface and to just, segment, because what I like doing with it is like doing blunt dissection, blunt dissect under the membrane and then back cut towards me. And I think that's a really easy, really safe way to segment. Instead of cutting as you move forward, blunt dissect under it. Use it almost like a viscodissector. That's what I like about the 27. You get under. I used to do a lot of viscodissection before. So it basically, separates the membranes from the underlying retina in a very good way. And I also like aspirating with it, because if the tissue is very firmly adherent, the tissue will fall back. So I use it as forceps. So I get on an edge of a membrane and I start pulling, but the aspirating force of a 27 gauge is so minimal compared to a 25 or a 23 or to forceps, because with forceps, sometimes you pull excessively and create a break. But here, if the tissue is adherent, it just falls back. So yeah, I think it's a safer way to actually peel.
Awesome. Terrific. Thank you, David. Thank you, Maria, for awesome talk and important insights as always. Our final speaker is Dr. Adrienne Scott. She's Associate Professor of Ophthalmology at Wilmer Eye Institute at Johns Hopkins University. She was Fellowship Director for a number of years and is currently Chair of the ASRS Retina Fellowship Directors section. And she's truly the world's leader in sickle retinopathy, both in the management of the disease and then more recently in the imaging of it. She'll share some of that with us. And she's also doing some really cool work on artificial intelligence and imaging the peripheral retina. And she's working with David Chu, who we just heard from on that project as well. Adrienne, thank you very much for being here, and we look forward to your talk.
Thank you so much, Shanir, and thank you for the opportunity to speak today. Can you see my initial slides? Okay, great, thank you. Disclosure is non-relevant. So we know wide field imaging is become a staple of our retinal practice in diagnosis of disease, staging, screening, machine learning, management, including surgical planning, as we've heard very nicely summarized in the previous talks, and also to gauge patients' response to various treatment modalities. So what do we mean when we talk about wide field imaging? So let's go back and talk about what is standard imaging. This is the 7-field imaging created by the ETDRS that show the basic posterior pole 7-field standard imaging. So a task force got together to try to discuss what are the definitions of ultra-wide field imaging. So posterior pole has about a 50-degree field of view. Mid-periphery is considered wide field, 60 to 100-degree field of view. Far periphery is where we're talking the anterior edge of the vortex plane ampulla and beyond the pars plana, about 110 to 220 as far as the field of view. And then there's, of course, panretinal field of imaging. So I'll show an example of a case in which ultra-wide field imaging helped me quite a bit in a patient I saw in my clinic, 72-year-old man with a 20-year history of insulin-dependent diabetes here. And you can see from the fundus, you do see some blood hemorrhages. The perfusion looks fairly reasonable to me from this view. And so if we compare kind of the view of the posterior pole to what was evident when we looked at the wide field imaging here. So we get a lot more information. So you can see these areas of peripheral, possible neovascularization, significant areas of capillary non-perfusion out to the periphery. He's pretty avascular in the periphery and lots of blood hemorrhages. The ultra-wide field fluorescein angiogram was quite impressive compared to what I saw from my fundus exam with indirect ophthalmoscopy. You can see there's extensive non-perfusion and neovascularization here in this gentleman, and the posterior pole is relatively well perfused. So I used ultra-wide field imaging to guide me because this led me to initiate treatment with panretinal photocoagulation. I did try to use the ultra-wide field fluorescein angiogram as a guide, as I often will, and it's very, very helpful and it gauges response to treatment. And I did feel, putting them side to side, the pre-treatment on the left and the post-treatment on the right, there was a little bit less leakage after placement of panretinal photocoagulation. I try to use the ultra-wide field fluorescein as a guide. I laser areas of non-perfusion, although probably you can use additional laser as well. I can go back and fill that in. But definitely it can be used to illustrate response to treatment and decrease neovascularization. So we're getting imaging data more and more. It's more and more important for prognosis and treatment from ultra-wide field imaging. So the DRCR looked at this in protocol AA to determine if the extent and location of non-perfusion on ultra-wide field fluorescein angiogram is associated with worsening diabetic retinopathy step score or need for treatment. They looked at 508 eyes followed prospectively over a 4-year period of time with wide field imaging. And the DRCR found that eyes with greater overall NPI or non-perfused index carries a higher risk of diabetic retinopathy step score progression, and this was statistically significant. So certainly if their non-perfusion was greater in the posterior pole as to the mid-periphery, their increase for worsening diabetic retinopathy was certainly greater. And the presence of these PPL, or primarily peripheral lesions, was associated also with deep disease worsening. So here's an example of one of the cases from the study. You can see in the eye on ultra-wide field color fundus photography shows primarily peripheral lesions at baseline. And the fluorescein angiogram does show high non-perfusion. And this was the type of eye that progressed in the study to actually progressing to neovascular disease requiring treatment. So ultra-wide field imaging is also used for diagnoses and documentation of disease processes across a variety of diseases. You can see here this beautiful example of multimodal imaging, in which Karoubi and colleagues documented a peripheral retinal tear with subretinal fluid. Additionally, sometimes in diseases we think of as primarily macular diseases, we can get additional information from the periphery that can help. This is a patient who had macular RPE and retinal atrophy, and the ultra-wide field fundus autofluorescence actually helped highlight the pisciform flex outside the mid-periphery. So this was a patient who actually had Stargardt's disease, and the ultra-wide field fundus autofluorescence was critical in helping the diagnosis in this patient. This is an example from Chowdhury's paper showing how ultra-wide field imaging can be used in a multimodal fashion and montage to document things like peripheral neovascularization. You can see this beautiful image of peripheral NV with a cross-section through with the OCT here. This is an example of a patient that I had, and I think this is a macular case. I can see pre-retinal membranes, macular pucker here, but my ultra-wide field image is super helpful for me because this is a patient who has proliferative sickle cell retinopathy, not only with a macular pucker and macular fibrosis, but extensive peripheral neovascularization and from CFAN neovascularization. So this is the type of image that helps me to think about how I'm going to approach the case. This is a patient with toxoplasma retinochoroiditis that can show definite improvement of the lesion in response to treatment. So ultra-wide field imaging is super helpful to us. We use this to be able to work with the computer science team at Johns Hopkins to be able to identify CFAN neovascularization in sickle cell. So you can see here ultra-wide field images of patients with fibrosed or autoinfarcted CFAN lesions on the left, and a heat map was created after training a neural network to be able to teach the computer how to identify what is suspicious for a CFAN. And you can see the heat map where it's red, the computer is kind of getting that there may be some hint of a CFAN there forming. Again, we use this for screening for sickle retinopathy. You can see a CFAN neovascularization in the periphery there. And that was our kind of our poster child case in this study. This is a study in which we put an Optos primary wide field camera in the hematology clinic. And this is a study coordinator and a medical student, non-trained photographers who took these images of patients. We brought the camera to them. We brought the camera to the patients in the hematology clinic to be able to try to gauge, could we get reasonable pictures enough to gauge in a mass fashion, was this actually sickle cell retinopathy with actionable pathology? So we had mass graders evaluate these pictures taken by non-professional photographers to grade whether or not CFAN neovascularization could be identified. So we got a mixed bag of these pictures. When people show you images, we often show you the best of the best, but I'm going to show you what we got. This is our real world setting. This is one of the images we got that shows a black sunburst lesion, no proliferative sickle disease. That one's fine. You can see a bit of lash in the bottom. This one, a little bit of lash in the bottom. It's an upper lash because the picture is inverted. But you can see there's dehemoglobinized vitreous hemorrhage, some treated CFAN neovascularization in the periphery. Now we're getting to quite a bit of eyelid covering our picture. So is this good enough to gauge proliferative sickle retinopathy? Probably not. And then this picture, it's dark. You've got quite a lot of lid artifacts. So this was probably not, it was gauged as not good enough to gauge to determine sickle retinopathy or not. So we got a mixed bag of pictures. And this one, this is the eyelid practically covering the entire image, although, you know, you can still make out the peripheral fibrous CFAN in the periphery. So we got all kinds of images from our untrained photographer. So we thought about a study. How do we give the photographer feedback in which to tell that the ultra wide field image is good or good enough to detect sickle retinopathy? So we worked again with the computer science team to create an automated objective method to assess the quality of our ultra wide field images, to give labeling of artifact and specifics about artifact. What kind of artifacts are we getting? So again, a neural network was trained to create multi-label classification with 6 labels delineated, trained on a subset of 243 images of the Optos ultra-wide field fundus imaging. And we gave, we had a ground truth, which was me. I just looked at images, all of the images, and told the computer, was there artifact and what was it? Is there eyelash present? Is there lower lid obstructing? Is there upper eyelid obstructing? Is this image too dark? Is there dark artifact? Is the image non-centered? And you can see our results here, in which we should, with the distribution of the various artifacts there. So our model performed actually fairly well with reasonable sensitivity, specificity, and receiver operating characteristics were pretty consistent, okay? So this is a confusion map that just basically shows our true negatives and true positives that our algorithm is performing pretty well, and especially when it comes to things that are pretty clear, such as is there eyelash present or is there eyelid present? Okay, so here's an example of a good case in which the computer algorithm agreed with me. We thought the image had too much lash and other things. And this was where we showed pretty good agreement. And this is a case where, you know, the computer and I didn't quite agree on exactly what type of artifact that was present. So next steps is we're working to optimize this neural network to detect good versus poor images. We want to challenge the algorithm with external data sets. Happy to work with David Zhu and I have some work hopefully we're going to do together. So once we train our algorithm, how good is it? Can we take it on the road and test external data sets? Other retinal diseases, other imaging platforms. This is just done with the Optos, but what about the other imaging platforms for wide field imaging? How does it stand up? So generally speaking, in conclusion, the automated algorithm shows promising performance. It's important to tell the photographer what's wrong, not even just our novice photographers. I'm sure we all have photography issues where, you know, you send a patient for photography and you want a specific pathology imaged and you get something that you didn't want. So the photographers need that feedback in real time. And this is only going to help the patients improve utility and cost efficiency in wide field imaging. Of course, wide field imaging does have its limitations. Artifact, as we just spoke about, peripheral distortion, pseudo color, the expense. These cameras, especially the one like I just showed, are pretty expensive. So it's tough to be able to integrate it into resource limited settings, but we're working to do so. And it requires a certain degree of technical expertise in acquisition and still interpretation. It does not substitute for clinical exams. Some providers use this as kind of a way of an area to almost sometimes substitute for a peripheral retina exam. I think it's a good supplement to a good peripheral exam, but cannot be a substitute. Future applications include maybe we need to revise our staging classifications for things like diabetic retinopathy, retinal vascular occlusion. We mentioned screening and AI, and I'm particularly intrigued by the relationship between the peripheral retina and the central retina in diseases like ROP, fever, IP, diabetic retinopathy, and even sickle retinopathy. So I think wide field imaging is definitely going to add to our knowledge base there. I'd like to acknowledge my co-authors, particularly the colleagues from the Johns Hopkins Malone Center for Engineering and the Hematology Department. Thank you for your time.
Thanks, Adrian, for an awesome talk as always. So how do you envision us, even in your advanced work, there's some role for human graders, some role for, machine learning and AI graders. How do you think we're going to navigate that? Do you think there's going to be a role for both? Do you think we're in a transition zone and it'll eventually become AI? I'm going to ask you to look into your crystal ball.
Yeah, this study was illuminating in my crystal ball for that reason, where there were some cases where, I did better than the computer, and which I would hope so. So I don't think we're going to be able to, I think we all have job security because the computer is only as good as what you put in and what you train. And so I really think there's nuance and some clinical judgment, pattern recognition that we still have compared to an algorithm. You can teach an algorithm only so much. So I think sickle is a great, disease to study because there's a binary, is it there, is it not type of feedback that you can get. Is there proliferative disease or not? And that feedback is actionable and potentially site sparing. So, I think we still do have job security and all this. And it just basically, I want this to be, this is a patient that needs to be in front of Dr. Garg or, Dr. Javeri. Not that this patient has this specific disease per se, but there's more investigation and real-time exam that needs to be done.
Terrific. Well, we went through 90 minutes of awesomeness very fast. And I want to thank all of our speakers and Dr. Sharma and Dr. Varma for allowing us to participate in this. I learned a lot and I hope you all did too. And we look forward to seeing you again soon. Thank you.
Thank you, everyone.
Thanks, everybody.